New Delhi.
Darling of Unani.
Yes. With his support, I guess with his support, our institute, our academic section at NRM SD Hyderabad is doing wonders, actually.
Thank you, sir.
Now I request Dr. M.A. Wahid to do the honors for welcoming, although he is our guest, but then he is actually on both sides welcoming the host, Dr. Yunus Bunshi. See, she's coming. She's coming.
Get the flower from such a personality.
And yesterday we all saw under his leadership what NRM SD Hyderabad is doing. It was a clean sweep, I should say it again, although he's himself is saying it. He's so happy. But then I should say that yesterday we saw a clean sweep with Hyderabad bagging 4 research paper awards and a best performing clinical institute award. Anyway, we are always there. Now coming to the presentations, I request, we have with us Dr. Ragu Arakal, who is the Deputy Director General Ayush at the Ayush Vertical Directorate General of Health Services, Government of India. He holds an MD in Ayurveda from the University of Kerala and a BMS degree from University of Calicut. He brings himself with almost 2 decades of expertise in Ayurveda, public health and Ayush health policies. Throughout his career, he has held positions in the Ministry of Ayush, including Joint Advisor, and has also served as a postgraduate faculty at Gujarat Ayurveda University, Gujarat. With these few words, although I have a lot to say, but these few words I request Dr. Ragu to please come over and give his presentation.
Is it loaded here or there? There only? There only. Okay. Distinguished chairs and eminent participants, even though the temperature outside is a little bit hot, but here I think due to the less number of participants is too cold. However, I would like to make you engage with what is the current position of the public health as far as India is concerned in the context of the traditional medicine particularly, and specifically if some points are coming in the context of Unani, that also I will try to mention. Can we go to the next slide? Okay. Okay. No, okay. Yeah. So, if you see over a last 1 decade or so, a large number of initiatives has been taken by the Government of India, specifically in the context of mainstreaming the Ayush systems into the healthcare, and also there is a redefining moment as far as how the public health should be amalgamating the strength of Ayush systems. So based on that, so many schematic provisions have been made, so many areas have been identified. So what is the background of this actually? Specifically, what are the so-called strength of the traditional medicine to redefine the public health in the Indian context? For example, you can see the re-emerging the communicable diseases. That is one thing you are seeing over a period of time for the last 2 decades or so, whether it is dengue, whether it is chikungunya. Then we also seen new diseases, or what you call the COVID and other kind of disease spectrum which has invaded globally, and India is also not an exception. Then similarly, epidemiological transition, specifically in the context of India, we have a dual burden. As you know that actually whether it is a communicable disease, along with that non-communicable diseases are also very rampant, particularly in the rapid urbanization, globalization, and other fast changing food habits and lifestyle. So non-communicable diseases are also giving a more impact to the health system. And also the demographic transition. So when you speak about India, actually we specifically say that the population, the pressure from the population, even though it is an advantageous position, but ultimately as a health system is concerned, there are a lot of pressures from the population, specifically the aging population, the healthcare of the elderly population. And so all these things are actually giving a tremendous pressure as far as the health systems are concerned. Then at that time, actually, there is a need for a cost-effective, accessible, and sustainable healthcare solutions where Ayush can play a pivotal role. That is what the significance of the various initiatives by the government of India is clearly making a direction in that front. Specifically, you know that now a word which is generally say that antimicrobial resistance actually. So significantly the traditional systems of medicine can, at an early stage, can specifically intervene with their vast armamentarium of medicines and many measures of what you call the Unani regimental therapies and the Panchakarma and in Ayurveda and even yoga. And meaningfully, if we are able to integrate these measures into the health system, definitely many of these antimicrobial resistance and other things can be appropriately addressed. Similarly, the malnutrition, a lot of, yesterday you have seen that new products has been already launched during the inaugural session actually. So which shows that there is a clear way which is shown by the traditional medicine in the context of whether this nutrition, particularly the malnutrition stage in the tribal pockets and many regions of the country is required to be really addressed. Only systems like Unani and Ayurveda can have that kind of intervention so that at least for a long-term strategy can be devised for that purpose. Then comprehensive and patient-centered universal healthcare system, that is what whatever the policies that we have, whatever the schemes that we have developed is already mentioned in that context. So as far as public health is concerned, you know that the daily regimen and seasonal regimen and other aspects have been appropriately integrated into all the policies and programs of the government of India, particularly those programs which have been initiated by the Ministry of Ayush. Similarly, palliative healthcare. And you know that there is a national palliative program which has been formulated by the Ministry of Health and Family Welfare. Even the Ayush technical inputs are also taken into consideration while devising the palliative programs in the country. And many state governments are actively conducting the integrated palliative programs. Another one is rehabilitative care, specifically post-stroke rehabilitative care, whether it is Panchakarma, homeopathy, or Unani regimental therapy. These can be effectively integrated into the post-rehabilitative healthcare. So, in the context of the NCDs, you know there is a national program in our country that is called as, erstwhile it is known as NPCDCS, National Program for the Control of Diabetes, Cardiovascular Diseases, Stroke, and other illnesses actually. Now it is known as NPNCD, National Program for Non-Communicable Diseases. So there is a pilot project run by the research councils, including the Unani research councils in 6 states, which have been resulted in, which proved that actually effective integration is possible at that level, particularly in the district hospitals level, effective integration is possible. And with that, the patient outcome and the accessibility towards the traditional medicine has increased tremendously. And mental health also, we have premier institutions in mental health, in the, whether it is in Ayurveda sector, whether it is in Unani sector, whether it is in homeopathy sector, there are premier institutions are there where generally the mental health along with the yoga and other therapies actually we can easily have at primarily the whatever the long term, wherever the long term medication is required, this traditional medicine can be appropriately utilized. And maternal health also, there is a program called the RMNCH program by the Ministry of Health and Family Welfare. So we are now envisaging that to appropriately integrate into that program also. The modules, the discussion to prepare the modules are already going in the Ministry of Ayush. So shortly we will come forward with the integrated module for the RMNCH program. Similarly, geriatric palliative care, there is a lot of discussions are going on at the government level also for the senior care reforms, particularly in the healthcare sector. And Ayush is already part of the this healthcare program under National Ayush Mission. This is a centrally sponsored scheme wherein Ayush Vayomitra, there is a component which is called as Vayomitra, wherein specifically the public health outreach activities and specific targeted interventions are done in the community. Then as far as the policy initiatives are concerned, those who are not knowing about the national health policy, specifically from the clients from the abroad, we will like to make that in India, actually, we have very integrated policy directive, specifically for the mainstreaming of Ayush. Mainstreaming of Ayush, we mean that the one is a strategy of co-location, wherein primary health centers, community health centers, and district hospitals are co-located with Ayush physician and practitioners. Similarly, we have at every level, for example, the lowest level of tier we have identified as Ayushman Arogya Mandir. So this is a set of what you call primary healthcare network, which is actually Ministry of Ayush has given the responsibility to develop 12,500 Ayushman Arogya Mandir in the country. And we are happy to say that all these Ayushman Arogya Mandir are now made into functional status and comprehensive primary health care in terms of whether it is yoga, whether it is medicinal plants, whether it is preventive care, whether it is routine OPD care, and even outreach activities, along with integration to the with ASHAs already undertaken in the, this Ayushman Arogya Mandir. Then there is a different policies, enablers are already there, whether it is in the National Commission on Macroeconomics and even the National Health Policy 2002 onwards, actually a large number of enabling provisions has been made for integration of Ayush systems. So in the NHP, as I mentioned earlier, that the pluralism is a pivotal directive as far as the national policy is concerned. Then even in urban healthcare, whether in NCDs, non-communicable diseases, then leveraging the digital tools for Ayush. You may be knowing about the Ayush grid. This is a comprehensive architectural network for all the Ayush resources in a what you call along with the IT tools, whether it is in the healthcare services, whether it is in education, whether it is in the drug regulation, everywhere this IT enablement has been done through this Ayush grid. So there is a national sample survey organization. They have conducted a specific survey in the context of Ayush, where it has been clearly mentioned that if you know that what is the penetration of the Ayush systems in the country, you can see that this is a reputed organization in the government of India. They have undertaken a national level survey, which clearly mentioned that 95% of the rural and 96% of the urban Indians are aware of the traditional medicines, and 48% of the urban and 45% of the rural populations are using it actually, and very therapeutic as well as rejuvenative purposes. Then even the yoga is also quite popular in the country. 87 lakh rural and 1.1 crore urban households, pranayama specifically, asana 70 lakh rural and 90 lakh urban households, and meditation. So in this way, a significant impact is already been made by the preferences of the population towards the traditional medical system, including yoga. So this is the background in which we are actually working these schemes and policies. So for the key enablers, actually, we made certain national schemes, which is called a National Ayush Mission, then Ayushman Arogya Mandir Ayush, which already I have mentioned, then the co-location, then Ayush Grid, which also I mentioned. In addition to that, IPHS, have you heard about IPHS? Indian Public Health Standards. Indian Public Health Standards is already formulated for the modern medicine, actually way back in even 2022, it has been revised actually. But as far as Ayush system is concerned, we have actually formulated Indian Public Health Standards for all the Ayush hospitals and Ayush dispensaries and Ayush Arogya Mandir, which have been published in the last year, actually. So it is a set of standards for infrastructure, for manpower, for medicines, for clinical governance, on all quality aspects. So on that context, the Indian traditional medical system has been actually now made a set of standards which is known as IPHS, and it is expected that all the provincial or state governments will roll out this IPHS in the due course, because it may take a little bit time. It is not a 1 day or 2 day affair. Over a period of time, for example, next 5 years or 10 years, they will come to a stage that they can adhere to these IPHS standards. Then, in order to integrate all these traditional medical systems into the mainstream healthcare, there is a separate Ayush vertical has been created in the Ministry of Health and Family Welfare, where I represent that organization, Ayush Vertical, in the Directorate General of Health Services. Then integrative healthcare is not limited to that. In all the tertiary healthcare hospitals of the government of India, there is an integrated department is actually upcoming, and already 2 is already functioning. One is in Safdarjung Hospital, another one is in Lady Hardinge Medical College. And shortly we will also look into that Ram Manohar Lohia Hospital also to have that kind of integrated departments. In addition to that, regular OPDs, research OPDs are already functioning by the research councils, including the Unani Research Council in all these hospitals. As I mentioned that 12,289 Ayushman Arogya Mandir has been so far operationalized. Under the National Ayush Mission, we are also supporting the provincial governments about setting up of integrated Ayush hospitals at a district level. It is the ambition of the Ministry of Ayush and the Government of India to have at every district level, there should be an integrated Ayush hospital actually. So that target slowly we are approaching to that target. Then we have already upgraded the dispensaries into the Ayushman Arogya Mandir. Then even the concept, the holistic concept of Ayush Gram, that is also supported by the Ministry of Ayush 692. Then in addition to that, various public health programs are already rolled out under the National Ayush Mission. For example, I already told about the NCD program. In addition to that, maternal and neonatal care, Supraja. The intention of this public health program is to develop the teaching institutions as a full-fledged delivery points and the full ANC coverage through the Ayush systems, whether it is Ayurveda, Unani, homeopathy, or Siddha system of medicine. There, our teaching hospitals should be empowered to have that kind of, because you have the faculty. For example, Amrase in this one, you have the faculty in the Unani institutions, but whether they are actually undertaking the deliveries and whether they are undertaking the antenatal care and postnatal care, only if they are able to do so, then only the objective can be fulfilled. So based on that concept, actually, under National Ayush Mission, we are supporting the state teaching institutions to implement this component of Supraja. Vayomitra already I mentioned. Similarly, integration with NPCDCS. Karunya is a palliative care program. Many states have successfully implemented this program, particularly Kerala, and some other states are Chhattisgarh. They have recently undergone the training in the palliative care from Kerala, and they have already started to be implemented in the state of Chhattisgarh. Similarly, we advise all the state governments to have these public health programs so that the visibility and impact of these Ayush systems, particularly in the context of public health, can be more and more prominent. Then lymphatic filariasis. This is an area where it is a concern for the government of India. Recently, Honorable Ministry of Health Minister also flagged the this has to be appropriately addressed. And as you know that there are 274 districts specifically as an endemic for the lymphatic filariasis in our country. So their meaningful integration with Ayurveda, Unani and homeopathy can have an impact. It is proved actually. And in Bihar and many other states we have started this program. So this is the, what is the outcome of these measures? Over a period of time you can see, for example, Ayushman Arogya Mandir, the beneficiaries can be last 2024 till October, it has been enhanced into 9 crore 57 lakhs. In addition to that, various specific targeted programs like tribal health program, then scheduled caste, scheduled supplant program, then WCH, reproductive child health program. All these are outreach program, which is even outside the ambit of National Ayush Mission. Even the research councils are actively participating in it. And I will not take much time actually. Ayush and integrative healthcare, All India Institute of Ayurveda, there is a separate integrated departments are, in addition to the central government hospital, they are also set up in even administrative centers of this Kevadia Supreme Court and Kevadia in Gujarat, integrative oncology center in NCI Jajjar, integrative healthcare in Nimhans, and the Department of Ayush in all new and upcoming aims. That is also on the anvil, but it has to go more distance because already a lot of discussions are going on that front actually, but it is expected that in all the new upcoming aims, there will be an integrated Ayurveda department, Ayush department, so that at least the futuristic way of the complete integration at the tertiary care can be fulfilled. So nutrition already I mentioned, I will not go detail for that. This is the IPHS publication I referred earlier actually, Indian Public Health Standards. This is the Ayush vertical specifically has undertaken a task of developing the standard treatment guidelines for each system of medicine. Musculoskeletal disorders already we have published, and it is expected that throughout the country, as and when the Clinical Establishment Act and rules are implemented actually, along with that, this SDGs, it is intended that these SDGs will be part of that. So all our practitioners, students, teachers, everybody should be well acquainted with these standard treatment guidelines. So we intend to have a massive awareness programs on the SDGs, whatever we have published so far, and the capacity building measures have been national level TOT we have conducted. It is supposed to be continued in a cascading manner. So this is the musculoskeletal disorders. Now we are completing the metabolic disorders. Slowly we will evolve, and within the next 2-3 years, all the disease conditions which are amenable through Unani and other Ayush systems can be published by the Government of India. So as far as the One Health approach also, Ministry of Ayush is part of that actually. And you know that whether it is plant health, animal health, there is a significant role for the traditional medicine, whether it is Ayurveda, whether it is Unani, homeopathy. Lot of products are available, a lot of interventions are available. But this has to be assimilated into the mainstream so that at least that kind of boost is required to be given to specifically the traditional medicines in the One Health issues. So evidence-based Ayush practices in the public health, already our research councils are doing, a lot of research activities they are doing. And as far as integrative health research is concerned, we have 4 aims. There is an Ayush ICMR, integrated research centers have already been established actually. So they have undertaken very targeted research programs, whether it is geriatric care, whether it is gastrointestinal tract disorders, and even the cancer. So these aims, along with integrated centers, will pave the way for the specific research outcomes in the field of integrated medicine. So Ayurgenomics and gut microbiome study, these are some of the significant leads that Ministry of Ayush through various research councils has obtained actually, whether it is omics studies, whether it is gut microbiome study. So in a nutshell, what we would like to say that there is a significant role as far as the traditional medicine is concerned in the domain of the public health, but it should be tapped appropriately and judiciously and integrated in each level of healthcare services. So prevention and control of NCD is already mentioned. Functional integration through NAM, NPCDCS already I mentioned. Next, antimicrobial resistance. These are the specific formulations which identified the Unani research councils, which has been already discussed, and it has been already made as a target, specifically National Antimicrobial Resistant National Action Plan 2. Under that, even the Unani interventions are also part of that. Then collaborative research project, RRI, this is Unani Research Council already doing it actually. So what are the specific challenges? Integration with the mainstreaming of healthcare and awareness and acceptability. So a lot of what you call specific awareness programs and capacity building measures are required. For that, it is intended that even the national level capacity building measures are to be spearheaded, that we are trying to do it actually, but there are still challenges because India is a large country. Addressing their regional and peripheral needs and goal setting is having challenges. Standardization regulation, this is an ongoing process. We are also doing that one. So more public health programs with Ayush, policy support and capacity building, strengthening research and global collaborations. So in conclusion, Ayush is a sustainable, holistic and cost-effective solution for public health. Government initiatives are paving the way for mainstreaming. Future lies in evidence-based integrative healthcare. Thank you. Thank you very much.
Any question, please? Is there any query? Yeah, please. Please introduce yourself first.
I am Dr. Vigyan, and I am working as a research officer in Hyderabad, Research Institute. Sir, my question, जैसे आपने बोला कि जो कबालत अमराज सवाल जैसे डिलीवरी के लिए अगर वो नहीं है तो ये फुलफिल नहीं हो रहा है, बट एग्जैक्टली अगर जैसे मैं आयुष को सिस्टम को 4 साल से देख रहा हूँ, एग्जैक्टली ऐसा तो सर बिल्कुल ही मतलब नहीं है जहाँ तक मैं समझ पाया। तो इसके पीछे सर जो मैं रीज़न समझ पाया कि हम इस बात को जो हम जैसे लिखते हैं इमरजेंसी सर्विसेज आर नॉट अवेलेबल, सो इसकी वजह से मेरे को लगा कि लोग रिलाई कहीं ना कहीं लोग इस चीज़ पर नहीं करते हैं। तो
Actually, what is happening actually, even the curriculum if you see in National Commission of Institute of Medicine and the National Commission of Homeopathy, there is a what you call for certain set of emergency care is to be capacity building has to be evolved in the same institution. There are certain things we cannot do it actually outsourcing a contractual requirement of the modern faculties also indicated in the curriculum. That is what we have, right? So that has to be effectively utilized. And at least we have to make a conscious effort in the community that the antenatal care, postnatal care aspect is better in Ayush considering the significant use of the antibiotics and other things in the particularly in the pregnant and post-lactating women. So that kind of approach is only can be done only through specific interventions and the targeted capacity building. That is what we actually proposing.
Even if we can,
Some of the states, for example, Tamil Nadu, some of the states are already doing it actually. So while the integration to the Supranga complex, even the normal delivery, for example, Madhya Pradesh, some of the institutions they have a certain number of deliveries. So now it has been significantly increased actually. So that means it is a success of this program.
मतलब गवर्नमेंट ने ऑलरेडी इनिशिएटिव्स और पॉलिसीज पे काम किया है।
sir, since I have one suggestion, since you are in the planning of the whole Ayush system. So I have one document over here that establishing a 10-bedded Ayush hospital, in which out of 10 OPDs you have given 1 to Siddha, 1 to Unani and rest to the Ayurveda, number 1. Number 2, on allotment of the beds, there is not a single bed allotted to the Unani. This is the establishment rule. from Ministry of Ayush for 50-bed hospital. No, listen to me, just a minute. Since I am giving the suggestions that you should take all the components of the Ayush system along with. If there are out of 50 beds, there is not a single bed for Siddha, not a single bed for Unani, not a single bed for homeopathy, while as all the 50 beds have been distributed to the 5 components of the Ayurveda. Number three is functional requirement. Functional requirement you have given to to Kaya Chikitsa, to Panchkarma, to Shalya and Salakya. Then it is Prasutri, drugs and pharmacy, and Unani and Siddha, when and where required. Instead of going for if it is locally acceptable, why not we go for that it should be propagated. Let the people of the north in J&K accept the Siddha and not at the choice that if you like Siddha, then we will open the Siddha OPD. See, in the same way, in Tamil Nadu, let us propagate, let us have in every wellness center a Unani OPD so that people can know that no, there is one more component, that is the Unani component in the wellness center.
We have to give a full platform for the propagation.
Naturally, in every wellness center, there should be one Ayurveda, one Unani, one homeopathy, one Siddha. That is what I mean.
I can clarify it actually. This is a wrong notion that 10-bedded and 50-bedded integrated Ayush hospital is not having sufficient, because we have system neutral. As per the guidelines, if you see closely, it is a system neutral. As per the preferences of the state government, as per the prominent systems prevailing in that state can suggest that which system has to be accommodated into that Ayush hospital, and accordingly say that you can have even the 50 beds altogether for the Unani and the yoga. There is no harm in it actually, because the guidelines does not prevent it actually, whether it is 10-bedded hospital, whether it is 50-bedded hospital. As far as the nomenclature of the Panchakarma and other things have been given, parallelly, if you see that all the parallel terminologies used in Unani, Siddha has been already been given in that guidelines. So kindly go through that guideline, 50-bedded integrated Ayush hospital and 10-bedded integrated Ayush hospital. There is no demarcation of the system-wise beds. It is up to the states actually, because ultimately state they have to see what is the target population to be catered, what is the systems already available. For example, the remaining, there is a catering for this much of Unani dispensaries are there, then obviously there is a need of more Unani beds are required to be. So based on that, whichever the state governments are actually putting their proposal to the Ministry of Ayush, appropriately we advise. For example, as already mentioned, that whether it is Jammu Kashmir, whether it is in Andhra Pradesh, or whether it is Tamil Nadu, or some, whatever the states who are actually putting, you want to project the Unani systems, we never discourage in the Ministry of Ayush, and accordingly, appropriately, it has been approved actually.
Thank you.
Thank you.
Thank you very much, sir. Or one more thing, sir. While you establish the wellness center, let that wellness center adopt that village, educate them to live their life according to the Ayush, then only you can prevent the disease in the future.
So
This should be taken care of.
That is the wellness center का जो concept ही है, basically it is not a dispensary. It is not a simple dispensary. The major impact to be provided by the wellness center is to have the community outreach and to adopt to the public programs. That is why wherever this Ayushman Arogya Mandir is successfully implemented by the states, the community organization, the Panchayati Raj institutions, and all other clusters who are actually working in the field has been integrated into the institutions. So if you go through some of the state governments and review this program, you will understand how it is actually functioning. So wherever such a linkage has not been created, there obviously it has not been transitioned to that one. So we advise all the state governments to have that kind of institutional mechanism. There is a concept of Janarogya Samiti, JAS, wherein Panchayati Raj institutions and the public, other public representatives are also part of that committee, so that even for planning of annual planning of what is required for the next year, which disease condition has to be tackled. So everything that actually this Janarogya Samiti has been empowered, and accordingly the medicines which is required for example, seasonal disorders, all the medicines has to be made available in that dispensaries. Everything has been clearly mentioned in that our guidelines actually. But ultimately the implementation, because it leads to that even though how many hand-holding measures the ministry is doing in the field actually, some of the states easily adopt, some of the states is a little bit delayed in that implementation. So that is what. Okay, thank you.
School health program also.
School health program also. We actually we have this along with the RBSK, because RBSK, Rashtriya Bala Swasthya Karikram, it only address the screening and disability of the school-going children. So we thought that Ayurvidya, there's a program wherein along with the school-going children, actually we are advising the specific measures which is required for the healthy healthy aspects of the life, specifically in the school-going children, along with the yoga and medicinal plants, the awareness about the medicinal plants in the schools. But still, a lot has to be gone because only our target was 75,000 schools. But considering the large number of schools which is available in the country, I think a large way has to be gone. So there is now a renewed thinking in many of the states that these both program, Ayurvidya and RBSK, can be integrated together so that all the school children can be appropriately targeted. Thank you.
Thank you, Dr. Ragu, for that enlightening talk. Indeed, you covered a lot of aspects regarding the Ayush for public health and the initiatives that the government is taking. I'll take a minute and ask our chairs to please, as a token of appreciation, just felicitate Dr. Ragu for his talk.
Please.
Wonderful. Yeah. Nice meeting and nice to hear you also.
Please go ahead.
that सामने से better है. Along with the offline participants, there are almost 2,000, more than 2,000 participants who are viewing us online as the program is being live streamed.
Wonderful.
Also. Now, moving forward, if possible, I request all the speakers to please be with us till the end of the session so that we can at least have a group photograph, which will be good. If possible,
Sir.
because everybody has his own engagement.
You have to be here for a group photograph.
Moving ahead, we have the next talk from Professor Jugal Kishore, who is the Director, Department of Community Medicine, VMMC and Safdarjung Hospital, New Delhi. He will be giving us a talk on the integrating traditional medicine in public health systems. Although I have a long bio sketch, but as they say, a man is known by his words. So all of us, he needs no introduction, and as he speaks, he'll tell us more about him. Thank you so much.
Very good morning.
Very good.
Good morning, chairs. My work is already done by Dr. Ragu. When we talk about this public health system, he has discussed about public health system in India. I was thinking about what is this traditional medicine, so we'll discuss about this traditional medicine and where the Unani stands and Ayush as such. A lot of the work which has been done already in India is discussed in detail. Rather, many times it is repeated that how Ayush is now mainstreamed to our modern system of medicine. But the reality is still we have to go very far when we talk about this mainstreaming of Ayush in India. But yes, efforts are going on. But when we talk about traditional medicine, it's not just Unani or Ayurveda. Actually, it's a total sum of the knowledge, skills, and practices based on the theories, belief. That's the important part. Experience indigenous to different culture. So we have different culture in India, and people are there. who are practicing various kind of things. Many a time it is understandable and sometimes it's not. So when it is not understandable, uh, modern system does not have any right, or maybe the Ayush does not have any right to enforce the population to, practice certain things. So that's used in the maintenance of health. Ultimately, all of them are trying to maintain the health as well as the prevention, diagnosis, improvement, and treatment of physical and mental health. That's a very important part. So in India, system is there, and multiple systems are there, which are there in the community, which is practiced, and let's see that what is going on and how it can improve and in what way we can make it more scientific. So this practice is actually not only just Ayurveda, but Siddha, but Unani, and we have Iranian system, which is also, we can learn from them. We have the Chinese medicine, which has done wonderful in public health. Similarly, we have the Rohingya or maybe African medicines. They are all, in different cultures, different countries are there. Most of them are actually using herbal preparation and natural plants and animals. And that is why the concern of the animals and exploitation of the herbal or plants come into picture, because we are doing a lot of deforestation, and as a human race we must understand the relationship between the plants and animals. So these all components, when they are modified, they are used. So we are forgetting that actually, the modification of diet and lifestyle is very important. Promotion of yogas and cultural practices are very important in traditional medicine. So when we are developing these systems, we should also look into the true, definitions of those systems. If you just understand what is Unani or Ayurveda, it is not just drugs or it's not just herbs. It is more than that, and that should be practiced. In global scenario, when we say this traditional and complementary and alternative system, how much prevalence is there to use? Actually, it is a 40 studies-based systematic review, which gave range from 24 to 71%. So it's a big population in the world are actually using it. And another figure is telling that traditional medicine growing exponentially, and market for herbal medicines was estimated to be reaching to 83 billion in 2008 and expected to grow, and we may reach to 5 trillion economy by 2050. So huge scope is there. We should encash this, change. Now these are different countries where another study showing prevalence of traditional medicine use in terms of visit to practitioners. It is 26% globally, and it may range from 0 to maybe 70%, while uses varied according to 32 countries. So that's a very big study and wonderful. Now when we talk about India, then we have one study showing Ayush use is 6.5%, and for therapeutic purpose they are going for 7%. So almost it's a 13%, and the highest uses in Uttar Pradesh, and there are reasons for it. Similarly, in the lowest one is in Nagaland, where just 0.1% of the population use it. And it also is specific to different diseases, like the cancer, where in South they are using much higher as compared to other. But similarly, we have other, reasons, and then those all reasons has been found out in another study showing, in older population, that for what purpose they are using the Ayush. And we found that it varies because of the religion, residence, from where in the country they are located. As you rightly said, that in Srinagar, the demand for particular system is more as compared to others. Similarly, you find many pockets, even the caste, certain castes have a different preference for the, and then chronic disease like hypertension, diabetes, arthritis, they have more preference for, Ayush system as compared to other. Tribal population need more as compared to the urban or other population. So these are all published document and data which shows that the India, almost you can say 13% of it is using it. There is one study showing that how much money the US is, I have not found out anywhere in the world that how much money is spent out-of-pocket expenditure on Ayush. But the US data showing that self-care using the Ayush or maybe traditional system is almost 64%. And practitioner cost is 32%. So when they go to practitioner, how much they are spending, Ayush practitioner. And then you can see the yoga, homeopathic and relaxation therapy. So it's a combination of all. 33.9 billion, expenditure is there in US. So it's a big amount and goes to the, alternative system of medicine or traditional system of medicine. Now, when we talk about India, then there is one study showing more than 75% of population preferred to go to non-degree allopathic practitioner and also traditional healer for the first contact because of lower fees, made house call to patient who are all in a quick service. Like, if you call them, they will go to your home as compared to, the modern system of medicine. They will not go or maybe charging more. So because of that reason, many of them are, so we can say the traditional system is actually providing the services at a very low cost. That's a very important part, which is suitable for the country. Similarly, we have, the figures which shows, the percentage of respondent who use indigenous traditional medicine as a first preference. So you can see very popular, 39% says it's very common. It's a Nagaland data, and other is a private to private and private to traditional. So if they are not satisfied with the private, then they will go to, other private or go to traditional system. So that is the way they are preferring the first contact, which is more important, that how much they like traditional medicine. And there is then, if they are not satisfied with the modern system, where they go. So that is also very good. Now this economy is already stated. I think it is well known that the botanical garden of the world is India, and largest producer of medicinal herbs, and the forest of Himachal Pradesh, just only Himachal Pradesh, that produce 80% of the all Ayurvedic drugs and 46% of Unani drugs and 33% of all allopathic drugs, developed in India. So you can see that how much we have the phytochemicals availability to even the modern system of medicine. Now, even as early as Boer Committee, that says that, the government funded private system should be there, and it should have the preventive, curative healthcare services. And it has highlighted that use of the traditional system of medicine. Unfortunately, the value should be given to traditional system was not given, but yes, some amount of the private sector started growing after 1980s. So you can see the almost 40, 50 years, required to go to that level where the outpatients start having, more on the private sectors. So 70% of all outpatient visit and 58% all inpatients are actually now provided by the private sectors. So public system is now reducing and a private is emerging and becoming much bigger. And that is why their role is important. So we have to look into that how to involve them in a much better way. The quality of care, accessibility and affordability of healthcare services, medicine diagnostic as a challenge. And when the more private will come, these all issues will emerge. And that is why the government has to play a role here. Several policies has initiated after 2000, and that has launched to, the various programs and activities which has been highlighted, like the IPHS standard because of this National Rural Health Mission. Later on, it became the National Health Mission. That is now focusing more on universal health coverage. So just imagine that leaving the traditional system of medicine is not possible, in the country. If we are not giving any importance or not giving the value to traditional system or Ayush, we can cover the whole country. It's not possible. That is why their integration, their involvement is very, very vital for us, because large number of people are coming to. So this Ayush Bharat program is attempting to tackle these all issues both in hospital and outpatient setting. Now this is a system in India that at the grassroots level we have the sub-center or health and wellness center. Now the word is Ayushman, Arogya Mandir, although I don't know, should we call it a Mandir? I'm sorry, sir, but let it be the Kendra or something like that. Much would have been much accepted by people, but anyway. And then we have the PHC, CHC, and it is a district hospital. So promotive and preventive, which is the core of the traditional system, core of the Ayush, actually is in preventive and promotive. That is why involvement of these system into the sub-center and primary health center is must, And therapeutically, you can see that, it goes. So drug use, so somebody was asking about why not these all, emergency services and all that. That may not be required. Maybe I think let it be the modern system which is playing a role. But at least for the preventive and promotive, where I think our modern system is not able to provide the way it should have been. Now this one is already known that we have the norms, and one sub-centers to be 5,000 population in general areas, 1 in 3,000 in tribal and difficult areas. The primary health centers for 30,000 in general population and 20,000 in difficult and tribal areas. And community health center is one for 1,20,000 for general population, one for 80,000 population difficult and tribal areas. Now I'll just winding up. It's a very few more slides. It's showing that
you already understood.
Yeah, understood. Because sir has already done the work, which I am going to say. My point is that yes, it's very important, and we have to see in the government setup involving the private and how we can make it more to have the universal health coverage, which is a mandate of the country, and also the World Health Organization is asking us how much you have covered. We can say yes, 100% when it is possible. I think involvement of all these infrastructure created by the government, in terms of the sub-center, primary health center is robust and unique in the world. I think such kind of system is not existing anywhere in the world. So this system has to be utilized in a proper manner. So everybody can go there. Unfortunately, they are not going there, but rather going to the private sectors, where they're spending a lot of money and getting nothing. Then you see that this traditional system has to have the linkage and maybe more integration with the modern system, which can provide the promotive, preventive, curative, rehabilitative services. And most of the things has already been started by the government. What is required at all the individual hospital level or the medical college level or institution level, think that providing the health for all, public health, has to be, in more integrated manner. And in what areas? I have found out that they can integrate in nutrition, epidemiology, environmental health, communicable disease, non-communicable disease already started, but other like the demographic and family planning, maternal health, and geriatric. These are all areas where more domains between the two systems is required. Now, national policy on the Indian system of medicine and homeopathy is already described that, some kind of integration is required. Mainstreaming, according to the National Health Mission, is already stated. National policy has elaborated the integration with Ayush is for the promotion of, health services or healthcare services. So the government is pro to, such kind of integration. Now, our mind has to integrate, our heart has to integrate. That is why this existing integration, is possible when we are, exchanging our patient, exchanging our knowledge, and supporting each other for betterment of the population. Remember, all the time you have to think that, yes, they are getting the health services in a manner which is required. Now this Unani medicine already have the preventive and social medicine department that is playing a very great role of promotion and preventive medicine. They should use their manpower, use their skills in the community in much bigger and better way. They have to find the methods by which it can be more, because they are more taught in epidemiology, more in surveys, organizing camps, running the peripheral systems. So they are taught all the things which a modern system are doing it. So they come forward and do this all. Another one is that they are regularly already organizing. If you see
Sir,
the things.
Please, if you can,
Yeah.
please.
Which,
Because
And-
you are having 10
yeah.
minutes and we are already 45 minutes late. Please.
what is challenges actually is still, I can say, the cooperation and intersectoral coordination between the two ministries is nowadays is good, but otherwise, always we have, gaps. So more, joint sessions are required. WHO recognized the Unani system of medicine as an alternative system, and I think their practitioner has to join hand together. Now, Unani research has already been taught in many countries, and surgeries are not, as developed as should have been. Somewhere, I think, in the history, you have forgotten the importance of medicine, but many surgeons I have met in Unani, they are very enthusiastic, and if the services are provided to them and facility, they can do wonders. Similarly, other challenge is the consumer perception. Still, they don't have trust because only just few percentage of the population believe it. So that require more, outgoing services, talking to them, providing services, and then scientific validation is required and standardization required, which is the CCRUM is doing it. Lack of quality and regulatory aspect is also an issue. Limited evidence based on a study on efficacy and safety. We don't have the system of doing the animal study all the places. Somewhere I think this need to be strengthened. Lack of pharmacokinetics study of bioactive molecules is also a problem. In the end, I can say future is bright. Traditional system, including Unani, has an exceptional potential to become a global healthcare system, and it has to be strengthened worldwide by the efforts of the government, policymakers like us, and agencies which are supporting us to ensure that its overall upgradation, standardization, and improvement is possible. Health for all, universal health coverage of healthcare may be achieved with the support of traditional system, including Unani medicine. Thank you very much.
Thank you very much.
Any question?
Can take a brief one question at least.
I think we can keep the questions
Later
for
on.
tea break. We are already running late by
Behind the
45
schedule.
minutes.
Okay,
By
please.
45 minutes. I request the chairs to please felicitate Dr. Jugal Kishore with the memento, with the request to be with us until the end of the session. फोटोग्राफ तुम ले लो एक मिनट जस्ट अ मिनट शी विल टेक हाँ Thank you so much, Dr. Jugal Kishore, for that talk. Now I request our next speaker, Professor Suhail Parvez, from Toxicology Department, Jamia Hamdard, New Delhi. He will be giving his talk on neuroinflammation and motor function rescue, unveiling Majun Falsafa's role in Alzheimer's disease therapy. Please.
Sir, you are requested to be in time, please. because
And
we are already.
the time is restricted to 10 minutes. Initially, we had.
Although no, there should have been half an hour. 45
Directly you
minutes,
come,
because
you
it's
can
a big
come,
study.
come to the
Since-
methodology and your results.
So very good morning, everybody. It's a pleasure to be here as part of Unani Day, and yesterday was really memorable for me too. I thank the organizers for inviting me. So I will be very brief and just pointing out at some of the things that we found out in our studies. So, as we know, neurodegenerative diseases are a lot, and usually we come across AD, PD, and Huntington's. And the word dementia is actually the umbrella under which the Alzheimer's comes. And currently, the epidemiology is huge, whether we consider our country or we consider the Western world. And Alzheimer's actually is encompassing almost 80% of it. Now, when we have this, there are two things that come into the picture as pathophysiology: the beta amyloid plaque and the neurofibrillary tangles that are very visibly seen in the histoarchitecture of the patients. So, what we have is that when we look at the different mechanisms, it depends on we are following an amyloidogenic pathway, the mitochondrial pathway, but the majority of the issues come across as we are not aware that Alzheimer's is actually taking place in 4 different stages. In all of these stages, the point of action is different within the different spheres of the brain. The onset is different, the symptoms are different, and when we take into account all of that, a combinatorial approach is usually missing. So what has happened is that when we looked at the approved treatments in the modern medicine, they are basically the acetylcholinesterase inhibitors or the ones that are working on the glutamate. So when you see donepezil, galantamine, all of them are mostly approached as a symptomatic treatment. So what has happened is, of lately, we have this new drug that has come into the limelight, and it has been approved by FDA, which is Edulhelm. And this also has not been reported to give its effect. Now, drug repurposing is a thing that is not only limited to modern medicine, but it is also there in the alternate medicine. So what was we were interested in testing the Unani formulations in Alzheimer's disease. So what we did was to select one of the formulations, and for us it was the Majune Falasva. And what we did, we took 3 different models within our systems, because it has been reported in various therapeutical uses, and one of them is in Nisyan, which we call as amnesia. But its result in Alzheimer's disease was not explored. So what we did was, we took 3 different models: a cell culture model, a transgenic Drosophila model, and a rodent preclinical model. So the first model for us, the cell culture model, what we did was we took the Neuro-2A cell line. And in this Neuro-2A cell line, we used the chemical scopolamine. Now, different chemicals have been advocated. For cell culture, scopolamine has been advocated because it takes care of the cholinergic systems. For the animal model, beta amyloid is infused with the intracerebroventricular route, and the beta amyloid plaques are formed because of that. So in our cell culture studies, we exposed it to different concentrations of Majune Falasva, and we could show that not only in the cytotoxicity shown by the MTD assay, we also had the bright field imaging where we could show that how scopolamine is inducing the toxicity, and Falasva in different concentration is protecting against it. Also, in addition to that, for the neuroinflammation, we measure the interleukin 1 beta and IL-6 also in our cell culture model, and we could show the protection. Now this prompted us, okay, in the cell culture model, it is not cytotoxic and it is also catering for the neuroinflammation. We have this very nice transgenic Drosophila model. So what has happened is when you cross these, then you get a transgenic model that can be captured by the red eye. And here also, I will just skip the results. I will come to one important thing that we could found was that in the neuro behavioral measurements in this, the climbing assay and jumping assay, we had very nice results showing that Majone Falasfa was able to improve the neurocognition impairment that was induced by the beta amyloid. Now, the major study that we did was the preclinical model with the rodent, and there what we did was we infused the beta amyloid via the ICV route in both the hemispheres of the brain. This prompts the 21 days of treatment of beta amyloid that is forming the plaques within the brain. And then we gave 2 different doses of the Majune Falasfa. And now what exactly do we do is when we add all of these chemicals, as you can see, scopolamine there is advocated for the cell culture and the beta amyloid is advocated for the preclinical ones. So the results, what we could find was, this is for example, the bar diagrams as well as the flowcharts of the novel object recognition. Novel object recognition is actually a non-spatial memory test. So you can see that the red bar there shows that because of the induction of beta amyloid, the memory was diminished in the rats that were infused. And upon the treatment of Falasfa, there was a marked improvement in the scores. In addition to the novel object recognition, we also did the elevated plus maze. So all these blue diagrams that you are seeing, these are heat maps. These are all measured by the software Animaze that actually captures the movement of the rodent. And here also you can see that in the elevated plus maze, the score, the red bar showing the beta amyloid group is diminished, and there we saw the improvement in the Falasfa group. Now this neuro behavioral impairment was then followed up by looking at the mitochondrial ROS. So what we did was we isolated the brain, we took out the mitochondria, and we did 2 different sets of experiment. This what you are seeing is from a fluorescence spectrophotometer, which we call it as a fluorimeter. So the elevated red bar here is showing the elevated ROS concentration in the brain. And then when we followed it up with the flow cytometer experiments, again with the mitochondrial ROS and the DCFDA dye, it's just to corroborate our findings of spectrophlorimeter technique as well as the flow cytometer technique. Now this was again something that was followed up with the molecular markers. Now BDNF, the brain derived neurotrophic factors, and CREB, these proteins are known to be down-regulated in Alzheimer's. And when we supplemented the Majuna Falasfa treatment for 3 weeks in this, you can see that there was significant improvement in the expression of the BDNF as well as the CREB. And this was then again followed up with the histopathology, and as the hippocampus is the center for the learning and memory, we took 3 regions within the hippocampus: the CA3 region, the CA4 region, and the DG, which is the dentate gyrus region. And we could see that yes, there was marked improvement in the neuronal loss. So as these evidences put together, we propose a mechanistic overview that as the mitochondrial injury is significantly alleviated by the treatment of Majuna Falasfa, the neuroinflammation, the motor impairment given by the neurobehavioral scores, as well as the molecular markers, they are all kind of preventing apoptosis, which is known as the feature of Alzheimer's, the first step. So in addition to that, we also propose that further studies are definitely required where more molecular markers will be tested on, so that we can give an entire picture. So this particular study that we did has now these deliverables. Yes. So this is telling us that yes, in cell culture model, in the Drosophila model, and in this they are showing protection. The manuscript is currently under review in Life Sciences, and I would like to thank Professor Akram, who is the co-investigator in this CCRM project, and Ms. Pinky, who is working as the SRF. And thank you very much. I hope I am written there.
Thank you.
Thank you.
Nice
Thank you very
meeting you.
much.
Thank you.
Basically, the branch where from you are from toxicology, no?
Yes.
And there is not a single word of toxicology only in this. So why don't we stick to our own path? If you are from toxicology, go for the toxicological studies. If we are from biochemistry, go for the biochemistry studies. Why are we intervening in one another's?
See, I did the toxicology studies in the cell culture model. Yeah, that was already there. The cytotoxicity and everything.
So you have reported not any kind of
yes,
toxicity.
and pharmacology and toxicology goes hand in hand. Yeah, you cannot differentiate between the two. And even if
No, but we need more toxicological studies as a means of safety studies instead of whether it is because we know it works in this disease and that disease. But is there any kind of toxicity produced by this drug? And where from this medicine was procured?
Cell culture.
yeah, Dr. Akram, who is there in the
No,
Unani.
who manufactured it? No? Drug manufacturing.
I think it was a collaborative project.
Yeah, it's a
So
collaboration.
who from whom you procured the medicine?
So the medicine must have been provided by us, since it is a collaborative project.
So you
Hyderabad.
got it from us, no?
Yes, yes.
Yes.
Then I
Yes,
can
yeah.
assure you the quality. Otherwise, in the market you can't find the
we
quality
didn't.
product.
It's a
Because
collaborative
as a
project.
policy, the medicines are provided by
Okay, okay.
Is a
Thank you
collaborative
very
by
much.
your the pharmacy under you.
Thank you very much.
Hyderabad.
Sir, one question from my side.
I think
But
we
please-
are already. Just if you,
Be brief, please.
Sir, which extract you have used when you have done cell culture experimentation?
The extract that was given to us from yes. Aquacell.
Based on your vast experience, sir, basically these drugs are not extract. These are semi-solid formulations.
Doctors,
One of the major challenges
please
are-
introduce yourself first.
Myself, Ghulam Hussain. I am working as research officer pharmacology at National Research Institute at Unani Medicine at Ragu. So what issue we are following, we are experiencing that most of the formulation are semi-solid formulation. They are not extract at all. They are just suspension or semi-solid formulation, and it is difficult to treat them with cell line directly. I doubt that if it is that same semi-solid, then it is very difficult to treat them. We are also proposing the study on Macau model on the same formulation along with our classical theory in collaboration with NIPER Hyderabad. Let us see what these findings are in our supporting us that we should go for testing it in the stroke as well.
See, for the cell culture, we took the extract. Yes.
Extract of what?
The cell culture, we took the extract of the particular.
No, sir. Actually, we are asking that which solvent you have used. Hydroalcoholic, alcoholic, methanolic, chloroform.
We have used hydroalcoholic for
Maybe
this.
the extract was provided by the Department of Pharmacology.
No.
for details, he's here with us. We can discuss over tea. And I congratulate Dr. Sohail Parvez for his talk and his study, because that actually corroborates our findings that we are already doing clinical studies, plus the formulation is already in use for a long time, and it's a very potent formulation.
For the aged persons.
For the aged persons, for dementia, Alzheimer's, as well as for improving memory. It's a very good formulation. Now I request the chairs to please felicitate him with a memento. Because we need more such studies, clinical validation studies, as per the national formulary the council is already doing at all its clinical centers. But what we need is an evidence-based support at molecular as well as preclinical pharmacological level. The mechanistic studies, the molecular studies, that is what we need to support the evidence that is required. Moving forward, we have our next speaker with us, Dr. Tasneem Wahid, who is the Unani representative and chair of Professional Board of Ayurveda, Chinese and Unani medicine on the AHPCA, South Africa. She'll be giving us a talk on integrating traditional medicine into healthcare. Dr. Tasneem, please.
Ma'am, please take care of the time.
Just over 10 minutes.
Okay, thank you.
Good morning. On the special occasion of Unani Day 2025, I extend my heartfelt greetings to all the esteemed organizers, chairs, distinguished guests, and participants. May the peace and blessings of the Almighty be upon you. Your dedication to promoting Unani medicine and its holistic healing traditions is truly commendable. May this gathering foster knowledge, unity, and the advancement of well-being for all. I am truly humbled to be speaking with you all today, and I would like to extend my sincerest gratitude to the CCRUM and the Ministry of Ayush for organizing this momentous event. Your tireless efforts in promoting the rich heritage and principles of Unani medicine have not gone unnoticed, and I appreciate the opportunity to be a part of this important celebration. I look forward to sharing thoughts and ideas with you all. Before I continue, I would like to take a moment to remember Professor Rashid Bika, whom many of you have met before. Without his efforts and contribution to Unani medicine, I may not have been standing here today. It is through his relentless efforts that Unani medicine is now a registered practice in South Africa. A brief insight into my family history: my grandfather was born in India, and his grandfather was a Hakim. As a result, TIB principles have been an integral part of my life since my childhood, although I was formally introduced to Unani medicine by Professor Bika. In South Africa, Unani TIB is regulated by a statutory council, the Allied Health Professions Council of South Africa, or the AHPCSA, which consists of various professional boards that represent different traditional, alternative, and complementary systems of medicine and therapies. How does this work? Okay, it's fine. As a professional, G. It's okay if it's not. Okay, yeah, it's fine. Yeah. Okay. As a professional board member of the PBACMU, which is the Professional Board of Ayurveda, Chinese Medicine, and Unani TIB since 2021, I've had the privilege of serving as chair for the past year. I would like to provide a brief overview of the current status of Unani TIB in South Africa, some of the challenges we are facing.
Which slide?
The first one.
First one.
Yeah, it's just the heading, so it's okay if it's not working.
It is working.
Okay. Which one? This?
This one.
Okay, thank you. As a professional board member of the PBACMU, the Professional Board of Ayurveda, Chinese Medicine, and Unani TIB since 2021, I've had the privilege of serving as chair for the past year. I would like to provide a brief overview of the current status of Unani TIB in South Africa, some challenges we are facing, and some of our goals that we are working towards. So, in South Africa, we have 66 registered Unani medicine practitioners, of which some have dual registration. So some are GPs or primary healthcare nurses, and most are females. This limited number of doctors poses a significant challenge in meeting the growing demand for our services as Unani TIB physicians. One of the primary reasons for this limited number is that our training institute was faced with political challenges, which eventually led to a restriction of student intake over the past 3 years. This ultimately resulted in financial challenges for the training institute. However, my colleagues and I are actively working together to restructure and re-establish training in Unani medicine in the near future. Minimum competency documents are being developed with the aim of standardizing a curriculum in order to approach multiple institutes and medical colleges to offer training in Unani medicine. This will provide greater accessibility to education of Unani medicine across the country. Of course, this is a challenging journey ahead to achieve this, but we are committed and confident that together we will achieve this. South Africa has a two-tier healthcare system with public and private options. The public system is managed by the Department of Health. Although Unani TIB is regulated by a statutory council, we receive no government funding and we are not officially part of the public health sector as yet. There is no formal integration between the available public healthcare and services offered by a Unani TIB physician. However, in private capacity, we have demonstrated success in integrating within a multidisciplinary setting. The Unani TIB clinics that were established in Cape Town by Professor Rashid Bika and the Ibn Sina Institute were primarily open to support the training of Unani students, but they now service the community in which they are based for the last 2 decades. A patient referral system has been established between the public government hospitals in the area and the TIB clinics. This has resulted in TIB securing a reputation as an effective, vital system of medicine where thousands of patients are treated at the clinics annually. TIB practitioners have been voluntarily working with various organizations, joining and also initiating outreach programs to lessen the public health burden by running clinics for the low socioeconomic communities to have access to free treatment. In doing so, we have demonstrated successful integration into interdisciplinary teams with patient feedback indicating high satisfaction rates. At these clinics, patients have access to allopathic GPs, dentists, physiotherapists, and other allopathic specialists alongside TIB doctors. This exercise has enabled Unani medicine to be better understood by our allopathic colleagues and has provided education on cost-effective methods to manage diseases such as dietotherapy using TIB principles, as well as providing much-needed treatment to the communities. The NHI, this brings us to the NHI, the National Health Insurance, which is a financing system in South Africa that aims to provide affordable healthcare to all citizens, regardless of their socioeconomic status. It is a centralized fund which is funded by taxes that buys healthcare services from private and public health providers, which will provide all citizens with affordable healthcare. The act was signed by our president in May 2024, but will only be implemented in phases over the next few years. The Allied Health Professions Council is actively working towards meeting requirements needed in order to become providers of services of the NHI. As Unani physicians, we are able to offer valuable and effective service at various levels of both primary healthcare and the public healthcare as a whole. For example, at a most rudimentary, non-invasive level, TIB lifestyle advisors can be involved in educating patients in preventative medicine and health promotion. Secondly, basic health screening could lessen the current burden borne by the primary health care providers in the public health sector. And lastly, TIB doctors may offer treatment of chronic and acute ailments, sharing the load of our allopathic colleagues. Bear in mind the strength that Unani medicine has in treatment of skin, liver, and other chronic conditions that the allopathic system has limited options of treatment for. We appreciate your advice and prayers to help us achieve this outcome as we are actively working towards it. The scope of practice. As part of our efforts to meet the requirements of being part of the NHI, we have revised our scope of practice in 2024 to align with international standards, considering that Unani medicine in South Africa excludes surgery and certain regimenal therapies. The revised scope of practice has been submitted and we are awaiting promulgation by the Minister of Health. We are working towards and look forward to expanding on this by facilitating training and upskilling of our practitioners to utilize more regimenal therapies like heredotherapy once the scope of practice has been promulgated. South Africa's rich heritage of herbal medicine allows us to utilize local herbs alongside popular Unani herbs. Due to restrictions imposed by SAHPRA, which is the South African Health Products Regulatory Authority, such as high importing costs and restricting dosages in imported formulations, along with the restrictions of the current scope of practice of us not being able to dispense scheduled drugs, the strength of the South African Unani physician lies in their effective treatment plans, utilizing lifestyle factors, regimenal therapies, and only natural medicines. The invaluable World Health Organization benchmarking documents on training and practice and terminology were utilized in this process of revising our scopes of practice. And we are sincerely grateful to all those who involved in the formation of those documents for their time, effort, and expertise as they are facilitating the process of standardizing the practice of Unani medicine across the globe. I would like to note here that our esteemed colleague from South Africa, Dr. Mujib Hussain, was part of the expert panel that developed the World Health Organization benchmarking documents. Furthermore, our colleagues have also been involved in the process of developing ICD codes, which will further establish Unani medicine as an independent, complete system of medicine and to be recognized as such. Currently, medical aid schemes for private healthcare patients covers a very small portion of consultation and treatment fees, if any at all. For example, blood tests requested by Unani physicians are not financially reimbursed because they are seen as blood tests for therapeutic goals. This serves as a challenge in private practice because patients are forking out a substantial amount of money annually for healthcare, but are not given fair access or choice to utilize alternative or complementary medicine. As I've mentioned, we are actively working towards providing equal access of healthcare for all patients. As previously stated, we are working on restructuring training, starting with the postgrad in Unani medicine, and we are keen to re-establish undergraduate training as well. My colleagues will speak more on this. This brings me to an important topic to be discussed, which is hijama or cupping therapy. In South Africa, cupping therapy may only legally be practiced within registered disciplines of Unani or Chinese medicine. It is a therapy that the public is utilizing and turning to as a first-line treatment in many cases, whether it is warranted or not, from unregistered and improperly trained practitioners. The PBACMU is working on preserving the therapy as a tool to be utilized with traditional philosophy for optimum benefit to patients, and our priority is public safety. We are looking at international trends and various options on how to regulate the practice in South Africa, and one of the options in discussion currently is a tiered registration option based on the World Health Organization training and practice benchmarking document, where an individual may be formally trained to be a cupping therapist that works within a restricted scope of practice under a doctor.
Please.
This practice by unregistered therapists is now rampant, but as a limited number of Unani practitioners in South Africa, we are not sufficient to service the population adequately. In saying this, we would love to increase the number of registered Unani practitioners in South Africa, and the current process to register as a Unani practitioner in South Africa is to submit an application via the Allied Health Professions Council. And upon meeting the necessary requirements, an applicant sits for a board exam. Upon passing the exam successfully, one may register to practice in South Africa legally. If anyone requires any information on this process, I am willing to assist. We would be honored to have international Unani doctors join our register due to the demand of our services, and your expertise in research as well would be a benefit to our community. I hope you found the brief insight into Unani TIB in South Africa informative, and I look forward to learning and leaving with fresh perspectives on how we can navigate the future of TIB in South Africa. Wishing you all a successful and inspiring celebration of Unani Day 2025. I thank you once again for your dedication and hard work in making Unani Day a success. Thank you.
Thank you very much. The main thing for which the people were waiting, you give last slide. Thank you. Thank you very much.
Thank you, Dr. Tasneem, for your lecture. Please be here for your memento. Please be here. I request the chairs to please felicitate her for the memento, for the wonderful work she is doing in South Africa for Unani system of medicine.
she has already given the slide.
So you have.
Thank you, Dr. Tasneem. Now we have our next speaker, Mr. Mirakhimov Jamshid, who is the head department and director in the Ministry of Health, Director, Republican Scientific Practical Center of Traditional Medicine under the Ministry of Health of Republic of Uzbekistan. He has also worked as Ministry of Health of Uzbekistan in the Department of Organization of Medical Treatment, as well as in the Department of Integration of Traditional Medicine and Modern Medicine. Sir, please. He will be, just a minute, he will be giving us a talk on regulatory and legal basis of folk medicine in the Republic of Uzbekistan. Welcome to India, sir, and looking forward for your talk.
Thank you very much.
And we request you to be brief, please, because we're already exceeded the time limit. Na?
Хорошо. Хорошо. Ну, добрый день.
Good afternoon.
Сначала хочу поблагодарить правительство Индии.
First of all, I would like to thank you, Government of India, Ayush Ministry.
Unani medicine.
You have a translator, na? You please open your.
Okay.
Your translator.
Because people will listen to you, and you have to listen to him.
Yes,
So
sir, I know that.
mic is needed for you, not.
Yes, sir.
Yes, sir.
Is it work? Okay. I would like to thank for the special invitation by the Government of India, and particularly I would like to thank our Ministry, Ayush Ministry, for having me here to speak to in front of you.
Mic is not working, right?
Hello. Not working?
Working. Хорошо. Вот. Вот микрофон. Пойдет?
Hello. ठीक है यार इसमें कर लूँगा मैं हेलो चेक हेलो
Да, разрешите еще раз поблагодарить.
Please allow me once again to thank you all.
Разрешите ознакомить с текущим состоянием традиционной медицины в Республике Узбекистан.
Allow me to understand our traditional medicine system in India as well as in Uzbekistan.
Вчера и сегодня, сейчас я слышу доклады, очень похожи юнани медицины с нашей узбекской традиционной медициной. Я думаю, это говорит о том, что наши предки корни были или дружны, или родственными.
Yesterday I had reports on Unani, and today also I am listening to the practices of Unani in India and abroad, and I understood that in Uzbekistan also we have our system Unani is working over there, and we have very close relations, and I see very close relationship between Uzbekistan Unani and the Indian Unani system and system of Unani in other countries also.
Всем известно, что везде одно из направлений необходимо для жизнедеятельности человека – это совершенственная система здравоохранения.
It's a known fact that for health system, for providing better health systems, we have to try for excellence. So it's trying for forming a very excellent system of medical treatment.
Да, в нашей стране с целью создания качественного медицинского обслуживания для профилактики, диагностики и лечения заболеваний, проведения научных исследований, был доклад до нас, и лабораторных исследований стали актуальными развитие направлений традиционной медицины.
We have in our country we had a prophylactic medicine system, and we are also trying for creating a better treatment facilities for all the people. And I understood that today in reports also have seen that clinical tests are being done to understand which kind of system works well depending on the patients and other parameters.
Для этой цели в Узбекистане было издано несколько нормативных правовых документов по направлению традиционной медицины.
For this purpose, in Uzbekistan, we have worked out on various principles and found working on standardizing the system of medicines and formulating principles of including all kind of traditional medicines.
Как я говорил, что традиционная медицина в Узбекистане очень похожа на Unani медицину, потому что основатели и в Узбекистане, и в Индии, смотрю, до нашего был доклады, все одинаковые. На экране вы можете посмотреть, из каких материалов, из каких данных, из каких книг, из каких предков мы пользуемся. И исходя из этого мы можем взять и легко сказать, что у нас очень похоже на Unani медицину. История.
You can see from the slide also the system, the Unani system which is have been used in Uzbekistan. It's very similar to the Indian Unani system. From the slide you can understand the various aspects of these things. In most of the aspects, we are very Uzbek Unani system is very close to Indian system of Unani medicine.
Ну, как вам известно, что Авиценна, это мировое имя его, Абу Али Авиценна, он родился сейчас на территории нынешнего Узбекистана, вблизи Бухары города, в городе Афшана.
As it's a known fact, our Ali ibn Sina, he was born there in Uzbekistan, near city Bukhara. Как назвали город там?
Афшана.
In the city Akshana.
Мы очень широко пользуемся книгами тип ханунлары.
We are using a book of Al-Mulara.
Канон врачебной науки. Тип ханунлары.
It's a type of Hanun. It's a manual. It's a manual of medicine system of traditional medicine system which is being used in Uzbekistan.
Ну почему? Потому что его книги, они систематизированы. То есть начинается от анатомии, кончается до фармакогнозии.
Yeah, they are very systematically written books, starting from anatomy up to the stage of pharmacology.
К большому сожалению, у нас не только в Узбекистане и в Средней Азии, вообще-то в бывшем Советском Союзе, примерно в 1918 году было запрещено заниматься традиционной медициной.
The things, unfortunately, during Soviet Union, the beginning of the formation of Soviet Union, the use of traditional systems were banned in Soviet Union, not only in Uzbekistan, along with in other Central Asian countries. It was banned by the Soviet system.
Но недавно наш президент дал разрешение традиционной медицины. Это в 2018 году был издан постановление президента о восстановлении и возрождении традиционной медицины в Узбекистане.
Thanks to our decision by our new president in 2018, they have resumed the system of use of traditional medicines. In 2018, a decree has been issued, our Uzbek president. So then onwards, the traditional system of medicines are being used in Uzbekistan.
В этом постановлении написано, что деятели традиционной медицины, они имеют право работать после заключения специальной комиссии по лицензированию медицинской деятельности с использованием методов народной медицины, это при Министерстве здравоохранения Республики Узбекистан.
After that, there was a concept was formulated, and it was allowed to work under the Ministry of Health Service, Ministry of Health in Uzbekistan, and we were all allowed to work and to develop and use traditional medicines in Uzbekistan.
Данное постановление было принято в целях упорядочить, да, деятельность оказания услуг традиционной медицины и потенциала народной медицины, формирование нормативных правовых баз в данной сфере.
So in this, by this resolution, we were all traditional medicine system people, practitioners were allowed to work, and the ministry is trying to develop formulations, norms and standards for using various types of traditional medicines in Uzbekistan.
Конечно, учитывая стратегию ВОЗ, как вам известно.
Of course, considering the strategy of WHO, World Health Organization.
Министерство здравоохранения предпосылками, для чего нам нужно было это постановление, в Узбекистане отсутствовала нормативно-правовой базы, не было там.
The normative legal base wasn't existing there in Uzbekistan. That has been formulated. Now, under that formulation, the Ministry of Health, Uzbek Ministry of Health, are allowed to do the research in this field.
И отсутствовало ответственные лица, которые отвечали на это направление, да?
And responsible the head or the responsible people were not identified initially for developing traditional medicine systems.
Отсутствовал порядок.
There was no order on which the order was not, particular order was not there on which we could have worked.
Отсутствовала единая информационная база.
The unified information base wasn't there.
Кто чем занимается, никто не знал.
So who is doing what kind of people are involved in this, that system, that information was lacking.
Но сейчас традиционная медицина признается как дополнительная медицина к модернизированной медицине.
Now the traditional medicine is used as an additional aspect for the modern medical medicine system.
И эта деятельность начала лицензироваться.
These activities were now getting licenses also.
И лица, оказывающиеся медицинские услуги традиционной медицины, они уже несут ответственность за последствия своей деятельности.
They are now responsible for any problems come out in treating in traditional medicines. They become responsible people. If there anything happens, they become the responsible people.
Конечно, в Индии мы сейчас смотрим две разные министерства, да? Это Министерство Аюш и Министерство здравоохранения. Но у нас одно министерство, поэтому Министерство здравоохранения Республики Узбекистан взяло на себя уполномоченным органом, который контролирует данную деятельность.
It's a great thing that in India we have two ministries, Ministry of Health and Ayush Ministry, separate ministry is there. That's a great thing for India. But now we don't have a separate ministry, but we have only all traditional medicine system also working under one Uzbek Ministry of Health.
Министерство здравоохранения внутри была создана специальная комиссия по лицензированию традиционной медицины.
And the Ministry of Health, Uzbek Ministry of Health, formulated a special commission to work, and that is dedicated to work on developing traditional medicine systems.
Традиционная медицина внесена в номенклатуру видов медицинских специальностей. Раньше не было.
And at the same time, this traditional medicine system was included in the syllabus of medicinal institutes. Earlier it wasn't there. So under these formulations, they are included as a, subjects in most of the medical institutes.
Приняты санитарные правила. Окей.
So sanitary rules were formulated.
И в 2020 году было новое постановление президента.
In 2020, there was a new resolution by the President of Uzbekistan.
О создании Центра традиционной медицины.
He has allowed to open a center of traditional medicines.
И на экране его функциональные обязанности
The
написано.
functions you can see are there on the slide.
В 2022 году был указ президента о создании при центре стационарного
And
клиники.
2022, by the decree of Uzbek President, social system was formulated in under the Ministry of Health.
В данном слайде тут указано специалисты в какой области, в какой районе работают.
In the slide, you can see the what kind of specialist working in which kind of regions, that has shown there in the present slide.
И что выделяется плантации для выращивания лекарственных средств растительного происхождения.
So there, and then there are also doing research to identifying the various plants which are being used for the.
Я очень извиняюсь, что занял много времени. Спасибо за внимание.
Sorry for taking more time. Thank you very much for giving me the chance. If you have any questions, please, is ready to answer.
Thank you very much, sir. I don't think that we can take any query, but I have a suggestion that you, since we have the collaboration, you can adopt the laws and regulations what we are having over here, because that are the best.
Так что вы, так у нас сотрудничество уже есть, вы можете уже работать, если сотрудничество с ними, нашими экспертами.
Thank you very much.
Thank you.
Вас тоже вручают.
Хорошо.
Yeah. I request the chairs to please join us in felicitating the Mr. Mirakhimov Jamshid. I request the translator also to please join. Please, because you had an equal contribution, because without you we would not have been able to understand. Yes.
Please. We could have
Yes.
not done. We understood only because of you.
So the scientific talk credit goes to you also. Coming to the last talk of the session, I request Mr. Riyad Mohammed to please come up. He is the Training and Research Medical Director, Ibn Sina Institute of Tib, South Africa. Welcome to India, welcome to the conference. Is he with us? Okay, you are here. He's completed his MBBCH at the University of Witwatersrand, South Africa in 2017, currently working as a medical practitioner, and has gained extensive experience in both private and public sectors. Over to you, Mr. Riyad Mohammed, for your talk. And please keep it very brief, because we are already very
Yes, I'm going to try. Okay, this is okay.
Mic niche kar lo. Please adjust your mic.
Okay, perfect. Right, good afternoon, everyone, and thank you to all the organizers of this event. My name is Dr. Riyad Mohammed. I'm a modern medical doctor with a keen interest in primary healthcare and integrative medicine. Today I'm here as a representative of the Ibn Sina Institute of Tib from South Africa, where I was appointed as the Training and Research Medical Director in 2003. My role at the Institute has, however, expanded over the past year due to the sad passing of Professor Rashid Bika, who I was fortunate enough to call my grandfather. Today I'll be discussing the Institute and the development of Unani Tib in South Africa. So firstly, I would like to put the South African healthcare system into perspective. There are two separate systems that run in parallel, the public system, which is funded by the government through taxes, and the private healthcare system, funded through medical aids and direct payments. In 2022, it was noted that around 84% of the South African population uses public health facilities, while only 16% are covered by private medical schemes. This, as the President of South Africa has noted, has perpetuated inequality and is one of the driving factors behind the introduction of the proposed National Health Insurance Act. South Africa, termed the Rainbow Nation, boasts a unique blend of different traditions and cultures practiced by different ethnic groups, and while research is limited, it has been reported that up to 60% of the population uses traditional medicine as their primary source of healthcare before accessing conventional Western medicine. This, coupled with conventional South African healthcare facilities struggling to cope with extremely high patient numbers and often failing to meet the basic standards of healthcare for the nation, means that traditional medicine has a huge role to play in managing the burden of disease, especially within the primary healthcare sector. So over the years, the World Health Organization's traditional medicine strategy has provided a framework to promote the use of traditional complementary and alternative medicine. And in aligning with these strategies, the Ibn Sina Institute of TIB has for over 2 decades been at the forefront of the implementation, integration, and growth of Unani medicine within South Africa. So the Ibn Sina Institute of TIB is a public benefit organization established by Professor Rashid Bika in 1997. The institute is charitably invested in through assets and donations, where all profits are to only be used to fund philanthropic activities focusing on providing public access to education, healthcare, and other public enterprises. To this end, the Ibn Sina Institute of TIB was established to promote the practice and training of Unani TIB, or Unani medicine, in South Africa. In the late 90s, Unani medicine was largely confined to parts of the Middle East and the Indian subcontinent. Professor Bika went to extraordinary lengths to study the modality, communicate with universities and scholars who were leaders in the field, and eventually introduce the system to South Africa. Over the next few years, he went on to translate and transcribe literature to make the modality accessible to a global audience and further refine the practice, research, and philosophical principles thereof. In 2001, with international academic support, the Institute, together with the South African TIB Association, facilitated the recognition of Unani medicine with the Allied Health Professions Council of South Africa, where it was accepted as the Council's 11th modality under the name of Unani TIB. Professor Bika wanted to ensure that all aspects of Unani TIB in South Africa were supported, and to this end, he formulated a Unani TIB medical range that was officially recognized by the Medicines Council Control of South Africa in 2002. In 2003, the Institute established the training of TIB doctors at the University of the Western Cape School of Natural Medicine, commencing with both an undergraduate and a postgraduate program. The curriculum developed for the training was reviewed by Hamdard University in Pakistan, Aligarh University, and Jamia Hamdard University from India. After the introduction of the academic training of TIB in South Africa, the Institute established TIB treatment centers, which facilitated the practical aspects of learning for Unani TIB students. The vision from inception of the Institute has been to participate in the promotion of healthcare provision locally and internationally through quality, cost-effective, integrative medicine. In line with this vision, the Institute is committed to these objectives. So specifically talking about the tertiary training, as mentioned previously, in 2001, the Institute, together with SATA, initiated the recognition of Unani medicine with the Allied Health Professions Council of South Africa, which was approved, and the register for Unani TIB doctors opened in August of the same year. In 2003, the training of Unani TIB doctors commenced at the university. This included 2 in-depth courses. The first was a 5-year undergraduate program, which included a 3-year BSc in Complementary Health Sciences degree, followed by a 2-year specialization degree in either Unani TIB, naturopathy, phytotherapy, or Chinese medicine. The second course was a 1-year postgraduate diploma in Unani TIB, specifically aimed at medical doctors and diagnostic primary healthcare nurses. Practical training for both courses was conducted under the guidance of TIB doctors at the TIB treatment centers in the Western Cape. Over 110 Unani TIB doctors have graduated from the postgraduate and undergraduate streams at UWC. While the tertiary training of Unani medicine has unfortunately been phased out as of 2024 due to multiple external circumstances, communication with universities and organizations has continued over the years, seeking collaboration in efforts to reinstate the training of Unani TIB. In August of last year, due to a renewed relationship with the Allied Council, the process of the reintroduction of tertiary training programs has commenced. Discussions with local tertiary institutions, experts, and the council are planning for a 5-year undergraduate degree and a 2-year postgraduate degree in Unani medicine. So in keeping with its vision for health promotion and illness prevention, the Institute has consistently been involved in social development through multiple education educational courses and programs. This included short workshops and talks offered countrywide to all sectors of the community. In 2005, the Institute hosted training for over 750 home-based care workers, introducing them to the principles of TIB and the value it provides in illness prevention and treatment. At a time when there was very little information available on lifestyle modification, TIB provided easy-to-implement options for care of chronic conditions. In order to increase the awareness and exposure of TIB, the Institute presented various talks and workshops to complementary health practitioners, traditional healers, pharmacists, doctors, university students, schools, consumers, and various institutions and community organizations. In 2009, the TIB Total Wellness Division was established, which conducted many corporate and consumer-based workshops on healthy living, stress, hypertension, and diabetes. In 2010, a schools program was established. In 2020, we launched our first e-learning course aimed at consumers. A wide variety of informational flyers in multiple South African languages, as well as TIB videos, have also been produced and are used to educate the community. Another area in social upliftment was the development and training of a tailor-made TIB Lifestyle Advisors program. Lifestyle advisors are trained to empower, teach, and provide much-needed support to communities lacking in primary healthcare. Through this initiative, the Institute collaborated with NGOs and primary healthcare clinics to provide Unani TIB-trained lifestyle advisors as an adjunct to their services in care. Community workers were trained and placed at multiple institutions and organizations, integrating into conventional allopathic-run public clinics, providing primary health care in indigent communities. So in accordance with Prof. Bika's personal philanthropic vision, the Institute has always been committed to providing an effective and affordable healthcare model through education and awareness, as well as medical care. From its earliest days, shortly after democracy in South Africa, the Institute prioritized partnerships with government and NGOs, offering financial support to establish clinics to provide primary health care in underprivileged areas. Soon after the establishment of the academic training of Unani TIB in South Africa, the Institute opened Unani TIB clinics. In 2008, the Sarki Batman TIB Treatment Center was officially opened. Under the expertise of our committed TIB doctors, the treatment center assists thousands of patients annually. Comprehensive treatment and medical care is provided through subsidized fees, making the TIB Treatment Center a vital player in health provision in suburbs where unemployment is rife and the need for treatment incumbent. It is also the first of its kind in Southern Africa. So over the past 20 years, the treatment centers have also been used for extensive and ongoing research where, with patients' consent, treatment is monitored through the use of TIB treatment protocols, lifestyle adjuvants, and eliminative therapies, allowing the discipline to constantly improve and the theoretical principles to be updated. The research has resulted in multiple books and articles being published, all of which are available for free download on the Institute's website.
Please conclude in just 2
Yes.
minutes, please.
So sadly, Professor Bika passed away in November 2023. The TIB website has a tribute page dedicated to his lifetime contribution to Unani TIB, to pharmacy, philanthropy, and to his unwavering dedication to healthcare for all. Worldwide, there's a shift back towards traditional healing, driven by the rising prevalence of chronic lifestyle diseases and a desire for more holistic approaches to health and wellness. Traditional, complementary, and alternative medicine is a vital and often underestimated health resource with many applications that can be utilized in meeting the health needs of our population. The practice of Unani medicine in particular is progressively gaining global recognition, and Unani TIB has the potential to be at the forefront as an alternate provider of primary health care. In order for the activities of the Institute to continue, for it to fulfill its aims, objectives, and its commitment to the South African healthcare system, and for the sustainability of the profession, the reintroduction of the training of Unani TIB at the tertiary level is a priority. We are therefore open to collaborating with any interested universities and institutions, be it on the development of a new course or integration into existing programs. With the combined local expertise of the Institute and Unani medicine practitioners in South Africa, we have the necessary resources and knowledge to advance and maintain high-quality education in Unani TIB. We also have multiple research proposals currently in development and have commenced digitizing the practice, which will allow for the streamlining of data to be used for further research. So in conclusion, the Ibn Sina Institute of TIB and Unani TIB in South Africa has experienced its share of successes and challenges over the years. However, despite the challenges, we are consoled by an ancient philosophy that reminds us the seeds planted today will bear fruit in future generations. In the words of Professor Bika, in light of the numerous successes that we have achieved thus far, I have no doubt that Unani medicine can and will play a significant role in the future of healthcare. Thank you.
Thank you very much.
Thank you.
if there is any suggestion for South Africa or there is any query, please. Okay, I think we should finish.
Thank you, Mr. Riyad, Dr. Riyad Mohammed.
Sir,
Thank you for, yeah, sure, sir, sure.
Yes.
Dr. Jugal Kishore and Dr. Ragu, sir, actually they mentioned something about the challenges in integration of traditional medicine into healthcare system, and you spelled some solutions also. I want to add few more things. Number one, actually we need evidence-based integration. That is the research and validation to be continued to explore and endorse the quality, efficacy, and the safety of traditional medicine through drug research and controlled clinical trials. Then policy frameworks should bring practitioner of traditional medicine and conventional healthcare providers under one umbrella and collaborate each other to offer wide range of treatment options. Then developing interdisciplinary educational programs to train both conventional and traditional medical practitioners to facilitate mutual understanding and collaboration. Number 4, traditional medicine can play a complementary role in managing the diseases, especially in the areas where modern medicine is access is limited, particularly for cancer. Then community health workers should be trained in both the traditional medicine and modern healthcare can bridge to improve healthcare access and outcomes. Then standardization of standardization of medical practices and procedural management in ISM is utmost necessary in the current situation. Then lastly, the promoting, monitoring and evaluation of integrated treatments can help in adjusting policies and practices for better solutions. So these are the points I wanted to share with you. Thank you.
Yeah. Thank you so much, sir. I request the chairs to please felicitate Dr. Riyad Mohammed. And with that, we come to the end of the session also. Dr. Riyad, please. The last speaker has left the hall, I guess. We needed him for a photograph also. With this, we end the session. I request, we'll be continuing with the next session again. I request all speakers and chairs for a group photograph. For the program copy, if you scan the barcode on the backside of your badge, the program copy is available to all of us.
Speakers will accompany me, please. And also,
It's starting right now.
all the speakers will accompany me to the waiting hall for the tea, please.
The speakers and chairs. Yes. We'll be beginning with the next session now. For that, I hand over the hall to Dr. Shaista Uruj for conducting the proceedings of the session.
Thank you, Dr. Nigar. Assalamu alaikum, good afternoon. A very warm welcome to the session, to the 6th scientific session. And I would like, the theme of the session is Unani perspective on mental health and well-being. Since we are already running late, I think we should begin with it, and I'd like to call our chairpersons. No, sir. So our first speaker, first chairperson will be Professor Alimuddin Khumri, sir. Professor Alimuddin Khumri, sir. He is the professor and head department of Amraz Jild und Taziniat and in charge of the Mollijat department of National Institute of Unani Medicine, Bangalore. Yes.
Check, hello, 1, 2. Hello, 1, 2, hello, check.
So call करें? Phone call करें?
कॉल करेंगे आप, लेकिन मसला वो है वो साइलेंट
The next chairperson is Dr. Ram Pratap Meena, sir. He is the Assistant Director Chemistry, Central Council for Research in Unani Medicine at Headquarters, New Delhi. I also call upon Professor Mohammad Idris.
कहीं तो होगा, देखिए. Check it in your bag, pockets, bag. It's okay.
So Professor Mohammad Idris, sir, I call you upon the stage, sir. Idris, sir, is the former principal and dean of ANU Tibia College, Karol Bagh, New Delhi. So since we are running late, I think I'll ask a favor of the speakers to kindly cut short their presentation to just 10 minutes because we are already half an hour late. And I'd request Meena sir to kindly facilitate our chairpersons. To Professor Idris sir. Welcome. Idris sir को welcome के लिए बुला दीजिए. पहले करते हैं सेशन जल्दी शुरू करें हम.
वो अभी एक रह गए इसमें, वो नहीं आए थे. इसका हो सकता है शायद ना आए, क्योंकि previous session में one of that chairperson was not available.
Meena sir, kindly welcome our Professor Idris sir.
Thank you.
Sir, Idris sir को आगे छोड़िए.
Request to please start this session.
सर पहले फेलिसिटेट कर दें हम चेयरपर्सन को. आप इदरीस सर को. Next, I'd like Meena sir to kindly welcome Khumri sir. Khumri sir को बुलाया. Khumri sir को. Now I request Dr. Khumri sir to kindly welcome our Meena sir. Meena sir.
कर लेते हैं. नहीं, you are not host. Yeah, right. You are the chairman. Co-chair. You are chairing the session. You are privileged as chairman. हाँ sir. Sure. Lecture sir. Thank you.
Thank you. I now hand over the session to the chairpersons. Okay, sir. And sir, please, because we are already running short, we can cut short these speakers sessions by 10 to 5 minutes, by 5 minutes to only 10 minutes.
Okay.
They have 15 minutes designated for them. So now they will kindly try to finish their speak within 10 minutes. Okay, thank you.
Thank you. Thank you very much. I wholeheartedly welcome to my co-chairperson, Professor Alimuddin Qamri Sahab. He's from National Institute of Unani Medicine, Bangalore, Government of India, and Dr. R.P. Meena. He's senior scientist working at headquarters Central Council for Research in Unani Medicine. Yes. Distinguished resource persons, speakers, audience, especially the young boys and girls, the young star of Unani system of medicine. I welcome all of you. As the madam told us, and rather she instructed us, just we have to follow the timeline. Since we are running late, a few minutes we are getting late. So I would request the distinguished speaker just to take note of it. Thank you. Thank you very much. Please, sir. So I would request about the first speaker. He's our guest. He has come all the way from the South Africa. Dr. Mujib Hossain. He's coordinator Unani Tib School of Natural Medicine, Faculty of Community and Health Sciences, University of Western Cape Town, South Africa. Welcome, sir. Welcome. His topic of lecture is transforming Unani medicine, spiritual care research in South Africa.
Thank you. Jazakallah. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. A warm welcome to all our delegates from around the world. And I start off by giving a special thanks to CCRUM, to Ayush, the Government of India, and to the distinguished guests on the panel and the chairpersons, my respected mentors and teachers. Today I speak about transforming Unani medicine, integration of Unani medicine solutions for the future. So looking forward, we cannot look forward without looking back. So we rely on our traditions to guide us, but we rely on our tradition to also transform us. So this research basically based on the current needs of South Africa. And it's also research that is funded by the National Research Foundation of South Africa. It is in collaboration with the Ibn Sina Institute of Tib and SATA, which is the Association of Unani Tib Practitioners of South Africa. Just how do I click? Okay. So just some quick background on South Africa. There's 9 provinces, 63 million people, and it's multicultural. About 80% of the population uses traditional medicine. So like you can see, there's beautiful scenery, there's beautiful colors, and like we have the scenery and the colors, there's diversity in the flora, fauna, people, and culture. So there's different forms of traditional medicines in South Africa, and all of the traditional systems are linked to spirituality and religion. And based on the work of Professor Rashid Bika, he understood that Unani medicine is a medicine for every region. And we believe that Unani medicine originated in Africa. Even though it is said that Hippocrates is the father of medicine, our African historians tell us that Hippocrates took his knowledge from ancient Egypt. So we find that the rich traditional knowledge of Unani Tib actually comes from Africa. And Professor Bika researched, and he went into spirituality and religion, and he went into it deep into his books on prophetic medicine, and he looked at it from medical ethics of Hippocrates, Galen, and Ibn Sina. And from there we noticed we had a need for the society. So we developed Tiba Nabawi, and we presented it on radio, on TV, but it was very much religious. And we understood that when patients came to our clinics, they wanted the spirituality. They came to Unani medicine for spirituality, and they came from all religions. So then we looked at research in spirituality, and these quotes that's mentioned here, that we are not human beings having a spiritual experience, we are spiritual beings having a human experience, come from scientific data. It says that as spiritual beings, we require spiritual care. So in the area of allopathic medicine, spiritual care is an ethics performance standard. So we ask this question: if we claim to be holistic medicine practitioners, where does spirituality feature? And that is what spurred on this research. So we look at various definitions of spirituality, and it includes the way people look at the environment, connect to the environment, and their belief systems. And if you look at the history of Unani medicine, you'll see that it's known by different names. In Africa, we call it Tib, Unani Tib. It's known as Greek medicine, Greek Arab medicine, Islamic medicine, Anatolian medicine, Uyghur medicine, and the list goes on. But one thing is for sure, that it is based on holism. And so there we ask ourselves the question, what about the science versus the art of care? And we find every region had a tug of war between the science and the religion. And we find in the Indian subcontinent, there's a big emphasis on the science, which is very important. But we ask the question, is there emphasis on spirituality? And what we have found that every region has a different view of spirituality. In some regions, it is something very sensitive, so we don't talk about it. But in South Africa, we need to talk about it because we went through apartheid, which suppressed our belief systems. So 3 decades after apartheid, we crave authentic medicine. We crave multicultural sensitivity, inclusivity, and that's the reason we have a mandate in South Africa to provide holistic medicines to our patient. Therefore, we looked into the literature of Unani medicine, and we found that in actual fact, in the medical ethics, going back as far as our Persian teachers, we know that Unani medicine rests on the shoulders of Persian giants. And we look at all of their works, we find that it is rich in philosophy and medicine. Ibn Sina says, you cannot practice medicine if you don't know philosophy. The two goes hand in hand. And his philosophy was based on spirituality. So Ibn Sina discussed medical ethics under patient interest, communication skills, and professional excellence. And if you were to align what Ibn Sina describes there, it aligns to what we call spiritual care competence. And this is documented in his Kitabu Shifa, the Book of Healing. And in many of his books, most of Ibn Sina's books is on philosophy. He authored 450 books, but we only know of 250. 150 is into the philosophy. So that means 150 of his books spoke about spirituality and spiritual care, while only 40 spoke about the medicine of the body. And there's evidence of this work throughout. And we find that Ibn Sina's view of the soul triggered the psychodynamic approach in psychology. So the entire holistic approach that is so well known in allopathic medicine today rests on the work of Ibn Sina. And therefore you'll find in various books in psychology, in the canon of medicine, he makes a reference to the importance of the matter of the soul. And I won't go into details too much, but you can go there, and I'm sure India, and we know the people in Iran, they rely on traditional literature. You will find all the information there. So in South Africa, we looked at Ibn Sina's work, and we found there's a close alignment to modern day findings regarding spiritual care. And therefore, when we look at Mizaj, there's a spiritual personality. When a patient comes to you, the reason why he's suffering is actually at a spiritual level. And there's randomized clinical trials to show that when you treat a person's spirit, it has a more profound effect than the physical medicine. So the summary of the research in South Africa, we have done multi-clinical research, mixed method studies, quantitative surveys, qualitative surveys, and we found that all the patients that come to us, the majority is seeking holistic care. They come to us because they expect to get advice on spirituality. But how do we advise? Is it religious advice? Is it spiritual advice? So therefore in South Africa, we developed spiritual care guidelines without overstepping people's belief systems. We created a framework to allow physicians to attend to the spiritual needs, but not enter into discussions on religion. All we're doing is telling the person that your belief system, that spirit inside of you, can heal you and supports the tabiyat. So there's two schools of thought in spirituality. Some believe that spirituality exists within each person, and the other belief is that the entire creation is together connected spiritually. And this was the belief of Ibn Sina through the concept of microcosm and macrocosm. So if you look at spiritual care competence under attitudes, behaviors, skills, you will find it totally aligns to Ibn Sina's medical ethics on patient interest, communication skills, and professional excellence. These are some of the publications from South Africa. So these publications targets the entire cohort, so students, educators, professional regulators, patients, and from there we built up enough information to design clinical research or to design clinical guidelines on spiritual care, and these are our references. Thank you.
Thank you. फॉर्मेट रखे हुए क्वेश्चन मिल सकते हैं ये लोग बात नहीं बता रहे थे सर एक क्वेश्चन फॉर्मेट कर देते हैं ओके if anybody wants to ask a question to the speaker please
spirituality is a part of human medicine or what? Because we have heard the ilaj bil ghiza, ilaj bil dawa, ilaj bil health, ilaj bil. So spirituality, does it come because if you want to do the scientific validation, if you are showing that we should integrate with the modern system of medicine, where does spirituality plays a role?
Yeah, so when we look at the view of India, we look at the dossier, so I look at CCRUM, and under there they say ilaj Ruhani is considered to be a very effective treatment. However, it is not within the scope of practice of a physician. However, if you look at the work of Ibn Sina, he believed that it should be, because when people come to you, they're actually coming to you with deeper problems, not physical problems. So these scopes of practice has been developed, has been influenced by politics, economics, social structures. So therefore, in our innovation and moving forward, we have to deconstruct that and look at what is real medicine. The unfortunate part of it is that allopathic medicine is telling us what is holistic medicine now, and now we have to pay attention because it's an ethics performance standard. But Ibn Sina set the standard hundreds of years ago. But in between, the science of medicine started to cloud the art of care. We became test tube scientists where we look at patients and we grade them according to their signs and symptoms. We didn't look deeper. So now modern medicine is telling us we have to bring back the art of care. So your question is a very good one, and that means we have to reconstruct. Thank you.
Thank you.
I would request the chairpersons to kindly felicitate our speaker.
Okay, yeah.
Sir.
Please. Sir, nicely delivered. Thank you.
As for the query, I would like to answer that there is something called Ilaj bil Ruhaniya in Unani medicine. So that was, we have set it apart for some time because we thought it was only incantations of religious texts and something. But spiritualism, I think, is the sensitivity of a person towards external stimuli, let it be physical or abstract. So the way you respond to anything is your spiritualism. I won't take time of the... So, yes, we have... Yes, we'll discuss it later. I don't want to, delay the session further.
I may interrupt you. That's very good question related to spirituality.
Yeah.
Actually, we cannot dichotomize the mind and spirituality and ourself. We have the part as a human being, so spirituality is main thing. Though we cannot define the techno-scientific terms, but it exists in terms of metaphysicals. We write the prescription, how about Shafi, thou heal. What is it mean? We address to the Allah. The Shifa is given by not medicines, not any device, not anything except Allah. So I think there is no scope of any contest or any critique. The people are going towards the spirituality. Spirituality is a part of any action, be it the medicine, be it any device, or be any intervention, And nowadays there is a lot of pressure on the WHO to include the spirituality in the definition of health.
It is
so
the integral part.
We will soon get the health definition by the WHO will be amended,
No, sir,
including
it is
the
already.
spiritual aspect.
No, sir, already the WHO issued the definition of health itself. It is indicated that not only the physical, mental, and spiritual health in terms is considered to be. The spiritual is also. That's I agree, sir. Yeah.
So we are not seeing the tipku tipki nazar se hum nahi dekh rahe. That is what it should not be combined. That's what.
Spirituality is the part of any intervention.
But if you take
generalize it. Sorry to say. Anyway, our next speaker is very dynamic. He's come from all the way from the South Africa.
She's
a little bit introduction. This is published in the Souvenir. Dr. Yomna Maid, properly pronunciated. She serves as council representative for Unani medicine on statutory body, which regulates certain traditional and complementary health professionals in South Africa. She is also a member of Education Committee, Finance Committee, chairperson of the Communications Committee of the Council. Additionally, she has served as both assessor and moderator for Unani TIP professional board examinations administered by the Council. Previously, she was a lecturer and external moderator for Unani TIP at the University of Western Cape, where she was also involved in curriculum development besides lecturing in public health at colleges and doing national assessment and moderation for healthcare courses for the development of higher education and training in South Africa for a decade. Dr. Mai operates a private practice in Cape Town, South Africa, where she is a registered practitioner of Unani TIP and registered counselor. She remains committed to ongoing professional growth, and she is dedicated to promoting awareness and understanding of Unani medicine's principles and practices. Madam, welcome. Welcome to DICE.
Assalamu alaikum. Good afternoon, everyone. I think that I might touch on some of the questions that were asked previously. Good afternoon. Happy Unani Day. I'm very happy to be honored to have the opportunity to speak to all of you today. So I am a Unani TIP practitioner and representative for Unani medicine on our regulatory body in South Africa. In our country, we have a two-part system, private-public, but there have now been moves towards a national health insurance for universal health coverage. Unani medicine is currently largely privately accessible. Now, as a regulatory body member and as a practitioner, I've been giving a lot of thought to how we can better serve the public, how we can integrate Unani medicine with the current conventional system of healthcare if we are to enter public health more prominently. Today, I'm going to focus on mental health care. So we currently navigate an era marked by increasing psychological distress, reliance on pharmaceutical treatment, and interventions that are not sustainable or do not resonate with patients. Integrating Unani medicine with conventional approaches to mental health offers a path towards more holistic and effective care. A combined approach could offer profound benefits and revolutionize mental health care. According to the WHO, 1 in 8 of us, that's 970 million people around the world, was living with a mental health disorder in 2019. Now, this was before a global pandemic and various political, financial, and human rights crises that have occurred since then. Next slide, please. Can I?
You have a slide changer there outside.
Oh, is there? Oh, there's an option. Sorry. Okay. So in 1948, the WHO gave us this definition. Health is the state of complete physical, mental, and social well-being, not just the absence of disease or infirmity. An amendment was proposed in 1998. Health is a dynamic state of complete physical, mental, spiritual, and social well-being, and not merely the absence of disease or infirmity. Now, this definition included the spiritual component of health, which had been lacking previously. But while the Executive Board agreed on the change, the World Health Assembly, which is the decision-making body of the WHO, did not end up passing it. This has been interpreted as a rejection of the spiritual dimension of health, and it is very interesting to look at which countries supported the definition, including spirituality, and which countries did not support it. So the WHO defines mental health as a state of mental well-being that enables people to cope with the stresses of life, realize their abilities, and learn well and work well, and contribute to their community. A little before the WHO, physician definitions of health emphasized normal functions. If functions are in order, it follows that the preceding physiological principles, what we call the umur al-tabiya, are in order. Another important takeaway is the importance of balance. Balance is maintained by tabiya, and when there's imbalance, we're more susceptible to illness. Unani medicine views mental health as a reflection of the overall balance within the body and the mind. Tabiya controls the body with the help of the kuwa, and the kuwa function via the corresponding ruh. Now, in Western philosophy, with the mind-body dichotomy, there is an understanding that the mind is subtle and the body is material. But in traditional philosophy, it's not only the brain which has the subtle component of the mind, but every other physical organ has a subtle dimension as well, the ruh. Health and well-being, including mental health and well-being, involves the physical, the subtle, and the spiritual dimensions of the human being. And acknowledging this and understanding how the dimensions are related allows for a more integrative and holistic approach to mental health. By linking the physical and the subtle, Unani medicine does not suffer the mind-body dichotomy confusion, and it is better able to understand how mental and physical health are linked and influence each other. With holistic treatment, with consideration of the supramaterial level of being, where we are truly whole, the level of existence which is not recognized in the conventional reductionistic system of medicine. Here, the whole disease or the disease process is addressed. So treating the root causes and a radical cure, rather than just relieving symptoms, is more likely. We are also able to determine treatments that may be useful to different conditions that would otherwise not be understood or possibly not even be discovered. So we do have a multifaceted treatment approach, including dietotherapy, for example, warming and moistening foods to counteract excessive dryness and coldness, regimental therapies to restore balance, pharmacotherapy to regulate mood, for example, or surgery when necessary. The conventional system uses pharmacotherapy such as antidepressants or SSRIs, psychotherapy, cognitive behavioral therapy, talk therapies, but also more and more they are using lifestyle modifications like sleep, exercise, diet as adjuncts to treatment. Treatments, however, tend to address symptoms more than root causes. Medications can lead to dependency and side effects, and psychotherapy may not always be accessible or often is not aligned with culture or the values of patients, many patients. Now, Unani medicine and conventional psychology or healthcare are not in opposition, though. They can complement each other. An integrative approach could mean the best of both systems with more patient-centered models of care. Diet is being considered in conventional healthcare, but diet with consideration of mizaj or sua-mizaj can help to optimize individual health. Regimental therapies like massage, hijama, or aromatherapy can be integrated with stress reduction techniques used in conventional psychology. And Unani psychotherapy can provide a more personalized approach to mental health care. Herbal interventions may have fewer side effects than conventional medications or may be used additionally for support or to reduce side effects. Integrating the three dimensions of existence to treat imbalance and health conditions holistically, addressing physical, emotional, and spiritual aspects, allows mental health or indeed any health condition to be treated in a truly holistic manner. There are parallels here with frameworks and understandings of each dimension in both Unani medicine and conventional medicine, as you can see in the table. But while Unani medicine integrates treatment in all three dimensions, conventional psychology can tend to separate them. So, a vision for the future. For the integration of Unani medicine in conventional mental health care, the following may be suggested. Professional development, with specialist training of Unani medicine practitioners in mental health care, interdisciplinary training, education of conventional practitioners on Unani philosophy and principles, and raising more awareness of Unani medicine in the public sphere. More interdisciplinary research, collaborative practice models with Unani practitioners working alongside, for example, psychologists or psychiatrists, and policy advocacy, promoting recognition of Unani mental health approaches. So the definitions shown at the beginning of this presentation show that it has long been understood that mental health is not merely an absence of disease, but it is balance, it's harmony. Unani medicine, the synthesis of medical traditions with ancient roots, offers us a timeless guide on how to maintain health and well-being in ways that are pertinent and important, acknowledging, considering, and honoring us as whole beings. Mental health care is complex. It's influenced by many things like lifestyle, environment, substance use, trauma, disconnection. As Unani medicine practitioners, researchers, regulators, students forging their pathways, we have an invaluable role in shaping the future of mental health care and healthcare in general. Let's continue to advocate for a truly holistic approach to enhance and strengthen current healthcare systems as allies working together to transform mental health care and to ensure that generations to come are able to benefit from the wisdom of Unani medicine. Thank you.
Thank you. Have you any question, comment, or critique from the floor?
No.
No? Thank you.
Thank you.
I request the
You have to say something?
No, I request you to kindly felicitate the speaker.
Okay.
Believing that this is a standard.
Please.
Yes, this speaker. it's already 1 and we are running late, so.
No problem. All the speakers are taking care of all time. Now the next speaker,
As a Professor Shakadi, sir.
please. Professor Ashar Khadir is one of the leading representative of Unani medicine, holding a qualification of BUMS, MD and PhD. His expertise lies in the basic principles, kulliyat tip of Unani medicine with a historical perspective. Currently he is serving as professor in the Department of Kulliyat Faculty of Unani Medicine at Aligarh Muslim University, Aligarh, with a remarkable career spanning over 28 years. Professor Khadir has established himself as a renowned scholar of Unani medicine. His academic contribution include 29 books, 57 research papers, 2 monographs, 14 books chapter, 1 edited book, 10 book reviews, 5 forwards, and 153 articles, all of which are widely read and frequently cited.
Yes.
Very illustrious.
Thank you so
person.
much, because we are running late, so we should also cut short the introduction of the speakers. I am very thankful to the organizers to call me here in a very good international conclave. As you know, that my talk of my stands on Unani perspectives in particular on mental health and well-being. So it is a very vast topic. So I have concised my topic. Next slide. Isme.
I think you can.
Yes. So I have been concise my topic on a very, very important topic as per the need of the hour. That is the Unani perspective concerning with psychosomatic disorders. And it starts from the stress, goes to anxiety, and ends with depression. And in Ibn Sina called stress as the inqibaz, but Majusi also used the word of tawattur, that is very synonymous, and that is hejan, and the third one is the pashmurdagi, depression. This is my resources from which I have taken the matter. I have narrated the books. Undoubtedly, on the top is the Al-Qanun, but subsequently that is the Mu'alajat-e Bukratiya, then Tarjuma wa Sharh Kulliyat Nafisi, and glossary of the terminologies set by the IHMMR in 1995. And now this is the chart which says about that what are the causes of the disease in philosophical manner and what a subject has. It is noted in the book as a maruz and araz, and that is known as Maqulat Ashra, and very beautifully narrated and speculated by Hakim Muhammad Kabiruddin in Kulliyat Nafisi on page number 156. So, for example, we have all the things at present. We are in a place with a kafiyat, kamiyat, and abode, and izafat. Izafat means I am telling something at this time, and I will tell another thing on another time. So this is my izafat or accessory association. And the essential coefficient factors here, the mental movement and repose. That is the very important wing of Unani medicine, where the mental health falls. And this is the chart. You can see here more correct. This is the chart that what is the holistic approach of Unani system of medicine. An appropriate combination is required among all internal and external factors of the body to maintain a good health with respect to physical, mental, and social well-being. And it starts from the body, and every circle spends with the anasir and temperament and humors and temperament again. That is the temperament of the fossil or environment. And after that, there are the 6 essential causes. And after that, there are the outermost circle of the social environment. For example, everything is there: exercise, mental health, education, religion, or your abode, your culture, your language, whatever it is. And here I have chosen a model of middle class Indian model, okay? So there are 12 basic needs. We are middle class persons, live in India. So what are our problems to give us stress? That is family relationship, transportation, mobility. For example, Jamin in Delhi, it is a very stressful thing. And economical security, work career, community, social relationship, home shelter, whatever it is. So every one of these effects on our mental health, and we have to very prone to keep these all the things intact at a time, which is not possible. Now, when sue-misaj occurs, that is known as when stress occurs, so out of 10, I have colored the 5 ones, that is kaifiyat, zaman, makan, and infial. For example, if you are going to catch your flight and there is a jam, and there is a time of flight which is on correct, stress begins. Stress will begin to occur. If you are on the right place, you will be calm. But as per your qualification, you will in the wrong place, you will be under stress. So I am not taking much time. The last thing is very important, that is infial reaction, and that occurs from the cellular level to the tissue level, because cellular level also has the centers and sensitiveness. That is physical. And when the compact body, which has been declared as a fifth tarkib, the fifth composition, which has a mind. So in our mind, whatever infialat nafsaniya and quwwat wahima, the decisive faculty we have, that decide that what we are we are the spiritual, or we are the believer, or we are the non-believer, or we are the naturalist, or we are the materialistic. So on that way, our mind will work. Now, this is the sequence Unani gives for a practitioner. So first of all, we have to take the first thing, that is only counseling. Because our physis or tabiat doesn't want to touch the body. Tabiat doesn't want to take or give anything materialistic. So that's why this sequence of the modes is not random. It is in accordance with the perception of the physis tabiat, and becomes the first step of usul-e-ilaj, the line of treatment. So when you are, as a physician, the patient comes to you, then you have to start counseling, ilaj bil tadbir, ilaj bil ghiza, drug therapy, and even surgery if required. Again, I have shown it by the change of color. The most probable thing is counseling. I will tell in the next slide. Because the psychological disorder fall under non-materialistic abnormalities, lead to abnormal behavior of the person. Thus, the most of the effective mode of treatment is the counseling to change the mental status of and the mood of the sufferer. And it is an example, but it will take some time, but it is very interesting, as example, sir. Please. I have taken some study on that, because you know that today the students are coming in BUMS after qualifying the NEET examination. Yes. But when the low merit student are unable to take the admission in MBBS, and they have been forced to take the admission in BUMS. So, and I am the teacher of the first year. So most of the time they are under stress, and they are trying a second attempt, and they are also trying a second attempt. So there is a period of 1.5 years, and that is sufficient to put a student under stress, anxiety, and even under depression. And most of the cases in Aligarh Muslim University or all over the India have reported that a student made the suicidal attempt. For example, you have to sit in the city of Kota. When there are 3 to 4 and 5 attempts, the student wants to finish his life. Because there is a pressure of the parents or the society or even the friends. Oh, you are not selected even this time. Oh, no, you are not a good student. So that is a very dangerous thing and important thing. The last slide is very, I am escaping is, I want to concentrate this slide. Sure. What is the line of treatment? In accordance to the Unani therapeutic principles, advanced therapies stands as follows. Now there is an amalgamation on the basic principles of Unani medicine, that what your advanced therapy lies. The line of treatment is that there are three objectives, there are three causes. Number one is tawattur, stress, infial. The second one is hajan, anxiety, and the last one is pashmurdagi. Now we have to antagonize ilaj bizid by the modes. Now note the usul-e-ilaj. What is the usul-e-ilaj? I am not taking any medicine, anything others, but what is the usul-e-ilaj? Number one is imbisat, because there is an inqibas, so you have to give the imbisat. The second thing is tafri, means hypnosis, anesthetics, taqdeer and taqwiyat in the last. So the usul-e-ilaj will stand as the imbisat, then tafri, then tanweem, then taqdeer if required, and in the last when the patient will be under the weak position by the mind, so we have to give the taqwiyat, that is volatilization. The mode of treatment. The mode of treatment, I am the treatment. I am the physician is the treatment. So I am the file active. And what I will do? Munbasit, I will take the munbasit. Every munbasit means relevant, relaxant. Relaxant, that means whatever be the relaxant. The second thing is mufarrah, excellent. The third one will be the munawwim, hypnotics. The fourth one will be the energizer. Anesthetic, muqaddar. And the last one will be the energizer, muqaddi. Now, how beautifully the basics of Unani tells there is no separation of modern, there is no separation of ancient. Only we have to stand on the principle. And you can say the counseling is that.
Yes.
Number one is counseling. Now your question is stand here. If someone believer is, if some believer is coming, we will say, okay, we will give the talqeen to them, shukr karo, sabr karo. Okay, but what will be about the naturalist? The second thing will be a tabdiliya mahol, the change of the abode, the change of the state, but that will not be handled, I think. The second thing is the physiotherapy. And physiotherapy, exercise, massage, hot bath, these are also maybe used any
As
of that.
management.
Either that will be munawwim, that will be muqaddir, that will be mufarrah, and that will be munbasit. The last thing is dietotherapy. So in dietotherapy, there are so many majuns and khamiras, dimaghi, and whatever it is, but elements and dry fruits, they are all there. And in modern, there should be some protein, minerals, and vitamin B6, B, C for the connectivity of the neural conduction, for the supplementation of the conduction of the neuron. And the last thing is the pharmacotherapy. Pharmacotherapy, now it becomes red, because from here the side effect starts. So the tranquilizers, hypnotics, barbiturates, and SSRIs, SSRIs. There are two techniques. And in the last, if the patient is natural,
Not responding to.
non-believer, okay, what I am doing, he will scratch his hair. Okay, he will go as a melancholia, pagalpan, madness. Then the surgery will be required. And there is an option of surgery even in Unani medicine. But the latest surgery is DBS, TMS, and capsulotomy. So by which we are there to tackle. But for example, what we have to do, the number one thing is counseling. Counseling. And for this, be happy and peaceful. If you give me only 1 minute. There is 1 minute. So what type of counseling we need, for example? So counseling, the first rule of the counseling is that the counseling should be in our mother tongue. Because your words should touch the heart of the patient. Your words should touch the heart of the person. So I have, for example, sir, I have written some poetry for that. If a patient come of psychic mentality and he beloved of the poetry, so what I will tell to you, to tell to them.
Yeah.
For example, only 5 couple
Stanzas of the
जिस्म से जान से वफा कीजिए, जिस्म से जान से वफा कीजिए, तंदुरुस्ती को देर पा कीजिए, तंदुरुस्ती को देर पा कीजिए, मुख्तलिफ हैं उमूरे चारागरी, मुख्तलिफ हैं उमूरे चारागरी, ये ज़रूरी नहीं दवा कीजिए, ये ज़रूरी नहीं दवा कीजिए. From here, the counseling starts about the mental disorders. Because there is a long poetry of आप तन्हा नहीं ज़माने में, loneliness.
You are not alone in the world.
आप तन्हा नहीं ज़माने में खुद को खुद से ज़रा जुदा कीजिए.
Separate
खुद को
yourself
खुद
from
से ज़रा जुदा कीजिए. बज़्म यारा में बैठिए अक्सर, बज़्म यारा में बैठिए अक्सर,
join the company of friends.
कुछ सुना कीजिए, कहा कीजिए.
Listen and speak.
कुछ सुना कीजिए, कहा कीजिए. And my last prescription for all of you, कम से कम एक बार दिन भर में,
मुस्कुराया कीजिए.
कम से कम एक बार दिन भर में रो लिया कीजिए, हंस लिया कीजिए. That is the magical situation. Okay? You go, and if you are sufferer, then you either you have to laugh or you can weep. That is will release your relaxation. That is the modification. I will sit with you about that. What is the combination in between the spirituality and Unani medicine? So I am with you. Unani medicine is totally materialistic.
Yes.
There is no room of any.
Exactly.
Unani
Spiritualism. Yeah. Yeah.
But
yeah.
I will take some other time with you, sir. And
Inshallah.
your question is very valid. Then you, for that, you have to go through my another topic.
One clarification from me.
Yes.
Spirituality
Is it different?
from psychology.
Yeah.
Psychology is
you're
science. Spirituality is a belief. And psychology, I'm MSc in psychology.
Yeah.
Because these in psychology we have different regimens like behavioral therapy, cognitive therapy. All these type of therapies are there. That was my question. Because what I believe is tip ki nazar se dekha kijiye. Because we are going to integrate. Okay. Another thing.
That's why I am saying.
We are running
Okay.
late.
No,
sir.
we have
two more
sorry,
speakers.
Professor.
During the lunch period, we have enough time. He is available till the evening. So, sir, please.
We have two more speakers.
Sir, one question related to you.
Sure.
You have mentioned the depression as pashmodagi. There is no the word pashmodagi is not mentioned anywhere, but the word hum is mentioned because one of the books of the Bukharat is Kitabul Hamma wal Ghamma. Hum is different, gum is different. Hum is what is depression.
Okay.
Pashmodagi is
There are.
We can discuss that later.
Pashmodagi is a Persian word.
Yes, Pashmodagi is a Persian
What
word.
is the difference between Unani medicine and Unani?
It's what.
You will go through from one of my articles, then I will be transferred.
Okay, sir. Okay, sir. Okay. Thank you,
I
Doctor.
request the chairperson to kindly.
Gamma is there.
Yeah, Hamma, you are right, sir. This is in the Arabic lexicon. But the Pashmodagi in Arabic.
Persian. Pashmodagi is Persian.
It is in
Okay,
Persian.
if I said Kavita Khatami, there are so many synonyms, but just it is an example. Okay.
Sir.
I just given this.
One
I
thing,
request the
if you are
chairperson
Thank
to
you.
kindly felicitate.
As because we are running late, sorry, Ashraf. So this is Professor Bukhari ji. Thank you. Of course, the discussion is very interesting. But
only one thing. My message. If you are the psychologist and I am a believer, I will never call 100% stress.
Okay.
okay, sir.
Thank you very much. We have given you the 15 minutes. Thank you, Professor. He is poet, shair. Oh my God.
I think we have a last speaker, sir. I think only one. I think so.
Thank you, Professor Ashar Qadir Sahib. Now, over the
Imtiaz
next
Hassan, sir.
resource person or speaker, very illustrious and very.
Very cool, it seems to be.
We have Dr. Imtiaz
Hassan.
He is an assistant professor at the Center for Interdisciplinary Research in Basic Sciences, Jamia Millia Islamia, New Delhi. With over 15 years of experience in teaching and research, his work primarily focuses on structure-based drug design and discovery. His lab specializes in identifying and validating the potential drug targets, particularly human kinase, by integrating the knowledge of protein structure with its folding and dynamics using computational biology and in vitro and in vivo methods. His team aims to develop novel therapeutic molecules. He has an impressive research portfolio with over 550 publications
Very good.
Very good. Very
Very
rarely seen. So,
So we're expecting
his
more.
work has garnered more than 19,000 citation,
Citations.
achieving H index of 67 and I index of 385. No doubt, this is
Very
amazing, amazing. So I would request.
Thank you, sir. Thank you for your kind words, and I am delighted to get the invitation from the CCRUM, especially the Unani Day, and it's my privilege. My work is, of course, it is entirely different from the last talk, all the talks, because it is totally research topic, and I was much impressed with the different ways of the Unani medicine to see the disease in different perspectives and from the different eyes. So I'll be adding just integrating the modern science with the Unani medicine and to get some outcome. That's my research. So you know that in the last talk was already on the depression and related to the mental health. So you know the mental health is a great challenge, and they are, especially after the COVID, the cases are increasing much higher. And in fact, now not older people, earlier people say it is the old age disease, but now it is the younger people are also getting that depression and anxiety, all those kind of disease. So that's what is a great challenge to the society. And if you see that the estimated growth of these types of the patients' mental health issue, you can see the dramatic increase in the number of the patients. This is the WHO data, and you can see this is also in terms of the global market point of view and drug discovery point of view. It's also a good market for the people who are working research in this area. And you can see in every 3 seconds, someone in the world develop dementia. So this is the very challenging diseases. And that's what we need the different perspective for the therapeutic management. So of course, to understand the therapy, first we have to understand the mechanism of disease, and this is the cause of the Alzheimer's disease. There are different types of the hallmark, and people are trying from the different angles, like you told us that you are trying from the Ruhaniyat and all those things. This is the scientific way to treat, because of the major hallmark is the production of amyloid precursor protein that's got aggregated and that lead to the diseases. The another hallmark is the tauopathies, that the hyperphosphorylation of tau protein that lead to the formation of aggregate and causes the Alzheimer's disease. So this is the mechanism by which the tau fibrils got aggregated and leading to the Alzheimer's disease. And for this tau phosphorylation is done by many kinases, many proteins, and that hyperphosphorylation lead to the diseases. So I'm not going into mechanism in detail because of the time constraint, but I'm just saying you that if the hyperphosphorylation tau occur, that it's forming the neurofibrils, and that fibrils accumulated in the brain, and that lead to the Alzheimer's disease. So if you see the Unani medicine, one of the natural way of the therapy for all the disease, but especially in the context of neurodegenerative disease, it has a large number of advantages, because having the less side effects, as well as it is easy to, the dose dependent, all those things, it's much easier to handle. That's what the people have taken this. But what I could do, I could integrate the modern science, the knowledge of 3 times the structure of protein, and combination with the Unani medicine formulation to see, and especially to conjugate integrate the 2 different disciplines together to come up with the new ideas and new challenges, to just bridge the gap between the 2 disciplines. So my lab is working on the drug discovery, and basically we are working on the kinases. Kinases are the protein in the human that is actually leading to the controlling almost all the phenomena in our body is controlled by the kinases, and that kinase is actually doing simple job. It is just phosphorylating one protein to make it the phosphorylated form. And this phosphorylation, dephosphorylation event is actually leading to the most of the, like the diabetes, whatever the disease, if you see, most of the things are controlled by the dysregulated mechanism of these kinases. And that's what the kinase is considered as one of the most attractive drug target. If you see the list of the drug target, it accounts for 30% of the drug targets are belonging to the human kinases. That's what we selected as a kinase. This is the classification of kinase, and you can see it is involved in especially 3 diseases like the cancer, neurodegenerative, and the diabetes. So my lab is working on all the 3 diseases, but today's focus will be the Alzheimer's diseases. I'm skipping this. So we developed the different strategy to use the natural product for the inhibition of the kinase activity, especially those kinases which are highly activated in the human body during the disease condition. These are some publications that we have produced, especially for the targeting kinases for the neurodegenerative diseases. So in this context, one of the kinase is called the MARC4, that's the microtubule affinity regulating kinase. And this kinase is actually doing although it is involved in many diseases, but I am going to just discuss its role in the Alzheimer's disease. So this is overexpression in the different types of cancer and different pathophysiological condition. But it actually hyperphosphorylates the tau proteins, and the hyperphosphorylation of tau protein lead to the aggregate, and that's what causes the Alzheimer's disease. So the basic idea is that if we will be able to control the overactivity or overexpression of the MARC4, we can be able to develop some therapeutic modalities. And these are some sites of the tau protein that got hyperphosphorylated. We have published a very excellent review on this area. Already we have ascribed. This is the structural feature of MARC4 that, of course, for the drug development, we should map the structure, and then we can map the structure of the compound and then see how, like a lock and key hypothesis, it could bind and then lead to the mechanism. So some of the inhibitors, especially related to the natural products in the Alzheimer's disease, that recently we have published, and these are the list of some work. So here I am going to present a very simple work that the project is given by the CCRUM. So we have taken the 4 different Unani plant extract, that's Withwania sonifera, then the Terminal chavula, Bacopa moneri, and Boswellia serrata. And then we have taken the extract of these plants given by the CCRUM, then perform the TLC, and you can see the TLC chromatogram of all these four products. Then we perform the HPLC to see what kind of pattern of the compound, and these are the HPLC pattern of all the 4 compounds. Now we have taken these extract and we checked that directly whether these compound could be able to inhibit the kinase activity of these proteins or not. And you can see here we have taken the MARC4, and as we increase the concentration of these compounds, you can see a dramatic decrease in the kinase activity of the MARC4. Then of course we tried to take the combination of these things, and we made a different types of the combination, A with B, B with C, and like that, and we can see an excellent combination where the maximum decrease in the activity was observed. The another protein that's kinase is the PDK3, pyruvate dehydrogenase kinase 3, and we again did the same thing, and you can see there is a decrease in some fraction, there is a dramatic decrease in the kinase activity of these enzymes, and also you can see here the combinations. Now we have performed again the fresh chromatography to separate this is the data of the only one plant, that the Bacopa moneri, and then we taken the flash chromatography to separate, enrich the particular fractions, and then we have taken that fraction and we have performed the kinase inhibition, etc. Now you can see there is dramatic increase in the IC50 value. It means that these fractions are actually showing the excellent kinase inhibitions. And also this fraction is showing the very good binding affinity. We measured through the fluorescence spectroscopy and very good binding affinity. Then of course we analyzed the fraction. We found the Bacopa side is and A on Bacopa side B is the major fraction in that content. Then we performed the molecular docking and we see how the protein and ligand bind together. And after that we performed the in-depth analysis, structure analysis. You can see these compounds are penetrated deeper towards the active site cavity, and of course it lead to the inhibition of the MARC4. These are some interactions they have done. Now the next question is that does this interaction is stable or not? So to that we perform the molecular dynamics simulation, especially I'll tell you this, just like a docking is the photograph and molecular dynamics simulation is a video. So we see how they structurally these are fitted and the stable complex is formed. And there are some parameters like the hydrogen bond interaction is maintained throughout the molecular dynamics simulation. And this is the calculation of the IC50 value. We can see the enzyme inhibition assay and the fluorescence binding studies. Ultimately, we also perform the ITC measurements because it is giving the thermodynamic pattern of how the protein ligand interaction happened together. And this paper was recently published in the IJBM. After that, we have performed the LCMS analysis to analyze all these fractions. I'm not going in detail, but I'm just listing you what kind of compounds we have observed and what would be the possible mechanism that we publish in the Frontiers in Nutrition. And after that, we developed the mechanism by which these Bacopa moneri extract is leading to the neuronal, especially as a neuroprotectant, how it maintains the neuronal health. And that was, so this is all about my work that we have developed some compound, we have isolated fractions of these from the 4 compounds, and we have checked that their kinase inhibitory potential, and that lead to the control of the Alzheimer's disease. Of course, this work is going on. Now we are about to test in the animal model. This stage is going on. And this is my team. I would like to acknowledge especially CCRUM for funding this project. This was under the collaborative scheme of the CCRUM. Thank you very much.
Thank you. Thank you, Imtiaz Sahib. Have you any questions?
We will continue. Now the best fraction we are
next
getting,
one is-
we will go.
Next, they're going to undertake on the animal models.
So my talk was different from the, I mean, the last 4 talks. That's all.
Very much keen, not different. No, you
Yes.
take this Alzheimer's, there is no medicine at all in conventional system of medicine right now.
Right.
Only one drug approved by the FDA recently, but
That is
it
also not
was
doing what?
criticized for having a lot of side effects.
Yes.
So, sir, I would like to add something. Alzheimer is a part of the
Amnesia and dementia.
dementia.
Morning habit.
Dementia is an umbrella term
Yeah.
for forgetfulness. Or interestingly, the Hippocrates, the father of Unani medicine, and modern medicines also, they also considered their father of medicine. And Galen, in these two stalwart of medicine from history point of view, they
too suffered.
didn't mention dementia. Dementia is mentioned as a Nisyan by the Unani physicians of medieval period. They were Razi, the writer of Camillus and Ibn Sina also. They have written profusely on this Nisyan. So earlier, so this is a contribution of pure Unani science. So thank you, sir. One component I would like to add. He is expert on protein synthesis and all about the proteins. He has very good lab. I visited there at Jamia Millia Islamia, or state of the art. So you are all aware nowadays the catchword of biomedical science is protein,
Yeah.
protein and proteins. Nothing but the protein. Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you, sir.
It's already 1:30 and we are too late. We have the last speaker now.
So the last but not the least.
Yeah.
दिल थाम के बैठिए मेरी बारी है. The bari is of
Dr.
Dr.
Nikat
Nikat, Sahiba Nikat. She is all the way from the Bombay.
Mumbai.
Dr. Nikat Sahiba is a dedicated and proficient clinician and researcher of Central Council for Research in Unani Medicine, specializing in Unani Medicine and extensive experience at Regional Research Institute of Unani Medicine in Mumbai. As a supervisor of clinical activities, Dr. Nikat Sheikh ensured adherence to CCRUM protocols, provided expert consultations, and monitored clinical outcomes across various domains, including mental health and chronic diseases. Their pioneering research includes exploring Unani interventions in managing conditions such as ADHD and cancer, with a focus on integrating traditional therapies with modern medicine. Beyond clinical research, Dr. Nikat has also made significant contribution to preclinical studies on anxiety and depression, further advancing the scientific validation of Unani treatment. In addition to clinical work, Dr. Nikat Sheikh Sahiba has held various administrative roles, overseeing pharmacovigilance, AHMIS, NAPH, NAM, STP research coordinations, while also facilitating collaborations with leading institutions such as IIT Mumbai and ACT REC. Dr. Sheikh continued to mentor young researchers and students, advocating a pivot role in advancing Unani medicine in both academics and
Over to
Now over to
Thank you, sir. Thank you. Such a nice introduction. It's a very detailed
Thank you.
introduction for me. Respected dignitaries on the dais, all my teachers and dignitaries of the dais, Assalamu alaikum and a very good afternoon to all of you. It's an honor to me to stand before you on this auspicious occasion of Unani Day, and I would like to thanks to DGCCRM, all the entire team of headquarter and the organizer for giving me an opportunity. So let's begin my presentation. The previous speaker, eminent speaker, Professor Ashar Kadir sir already covered lots of Unani concept of mental health, so I'll briefly go through. As mental health is what you think, what you feel, and how you react. So it's a physical, cognitive, social, and emotional combo. It's nothing but a mental health, and it's affect all the age groups, since from childhood to old age. And it's having lots of factors of environmental, relationship, physical, all the details have you already listened the previous speaker. The mental health prevalence also, if you, Yumna has already elaborated what's the mental health status as age and gender and urban and rural versus. So I'll quickly go through. The Unani concept. Unani having the concept of 4 humor, 4 mizaj, according to that 4 qualities, and even classical text and Atibbas mention the 4 personalities and 4 mizaj. And even though they said about what disease you may have as per your mizaj. For example, your mizaj is sanguine, so your personality will be very stable, sociable, energetic, and you will have the prone for the diseases like blood-related hypertension and inflammatory conditions or fever. Yeah. If you have a choleric temperament, you might be very ambitious, quite irritable, goal-oriented, and you're prone for the liver dysfunctions or biliary diseases, acidity, ulcers, and all. If you have a phlegmatic personality, then you will be a very calm and reserved person, maybe a little bit a lazy person, classical text says, and you are prone for the respiratory diseases, asthma, bronchitis, and even the lifestyle diseases, body retention, fluid retention disorders. And if you're melancholic personality, that is Saudavi mizaj, so you are very analytical, very perfectionist, and prone for the cancer, mental health issues, and any chronic illnesses, which is very rare to treat. So this is classical text elaborated very well about the body personality, prone for diseases, their line of treatment based on the individualized mizaj. If you see the mental disorders in Unani, so as I told, they mention about the gender, who will be prone for the male and female, the personality type, and the seasonal variation also mention the classical text for the mental health and diseases. Ashar Kadir sir very well elaborated the concept of mental health and the Unani correlation. Here just I want to one theory about the qalb and dimagh. It's a very close relation in Unani of qalb and दिमाग, और ये इबारत ज़ाहिर करती है कि कल्ब की कैफियत ना सिर्फ जिस्मानी बल्कि ज़हनी और रूहानी सेहत पर भी असर डालती है. सो ये कंसेप्ट सिर्फ यूनानी का बहुत पिकुलर है, जो हम सोचते हैं, जो हम चाहते हैं और जो हम करते हैं. दिस इज़ द वेरी क्लोज रिलेशन ऑफ माइंड, बॉडी एंड सोल. Even if you see a recent publication also shows the relation between mind, body, and soul, where your thinking power, all the situation, emotions, what you are thinking is directly affected to your mental health. These are few publications for your references. Even the American Heart Association also saying the psychological health, well-being, and the mind-heart-body connections. This is the published paper which showing the connectivity between heart and brain. Classification as it is maddi or ghair maddi. This is the correlation between the classical symptoms which is mentioned in the Unani text and what modern system correlate with anxiety, depression, and the chronic stress. I'll not go into detail. This is the maddi symptoms where the madda is involved, dam, balgam, safra. So then we can correlate with the psychosis conditions in the modern contemporary systems. So diagnosis is based on the symptoms, emotional, psychological, and physical, and the imbalance of kafiyat and humor or mizaj identification of a person, and of course the lifestyle factors assessment. And the modalities, we have to be mood uplifting, reducing emotional instability, promoting relaxation, and the improving sleep quality, enhancing the cognitive functions. So for this, we have the 4 line of treatment: ilaj bil ghaza, ilaj bil dawa, ilaj bil tadbir, and ilaj bil ruh nafsani, which is a very hot, controversial topic. so I'll not go into detail, but just superficially, I will go through ilaj bil ghiza. You know, the kamiyat and kafiyat of ghiza is very important in mental health, and even modern publications also says the importance of nutritional in psychiatric conditions. Ilaj bit tadbir, here are elaborate few tadabir, which is a very good or promising result in the mental health or mental illnesses. For example, cupping. So this is the published paper which shows the effect of cupping to release the anxiety, stress, and to enhance the mood and cognitive functions, and to improve the blood circulation. Nutul is also very promising tadabir where we can use in mental stress, anxiety, and depression. Even publication also shows their therapeutic evaluation in the efficacy of anxiety and depression. And lots of single and compound formulation mentioned for the Nutul we can use in our general practice. This is, you believe me, a very numerous nasal drug delivery systems are mentioned in the classical text as a Saud. Even we are working with the IIT Bombay, and Professor Muhammad Idris is one of my selection committee, sir, and sir sanctioned my project about ADHD. And we are using the Nutu Saud of nasal inhalation of aroma and local application along with the Unani formulation. So if you see Rogane Sukh, Rogane Badam, Rogane Kaho, Kadu, numerous medicines are mentioned as a nasal inhalation. You can take as a nasal drop. Even publications are also showing their efficacy. Lakhlakha inhalations also there. Lots of aromas mentioned in classical texts we can use to reduce the anxiety and depression condition. Even publication in contemporary system also shows their efficacy. Apart from Lakhlakha and Saud, there is a Takhtir, drop by drop in Khutur, and there the Tila, Zimadat, and the Nushukh and the Tadheen also available in Unani classical text. The regimes, even its need elaboration. I didn't have any publication to show their scientific evidences, but it's there mentioned in the classical text which needs to explore its scientific evidences. Massage is also very popular regimes for the in mental disorders, especially in anti-anxiety, depressive efficacy, and here are some few publications which shows their efficacy as a anti-anxiety, anti-depression. There are points are mentioned in classical texts where to do massage on soles or scalp or body massage to release this stress and anxiety. Oils are mentioned, light massage, heavy massage, types of all detailed SOPs are mentioned in the Unani classical texts for the regimes. Hammam also good regime to reduce, and Turkish bath is very famous for the mental illness and mental disorders. Sauna bath, and now there are the infrared sauna and steam. We can create SOPs also before and after for the mental health. Even Zakaria Razi mentioned कि शफाफ और गर्म पानी से हमाम का लेना जो है तो इंसोमिया कंडीशन में बहुत बेहतरीन इलाज के तौर पर देखा गया है. Then exercise, of course, exercise is a good for the mental and physical and the spiritual things. Then leech therapy also, as we know, the leech is secreting the bioactive compounds, herodine. Also, it secretes the neurotransmitters, which neuropeptides, which act on the neurotransmitters. And we know the function of neurotransmitter as anti-stress, anti-anxiety, which reduce the pain, enhance the mood, and act in the neurodegenerative disorders. We also have the concept of tankhiyah mawad. You may say the detoxification method by lots of systems, especially if you do purgation by GI tract, vomiting, and sweating by skin, diuresis by urinary tract, and the expectoration by respiratory. So we may use, this is the Unani single drugs mentioned in the classical text having the neuroprotective, hepatoprotective, cardioprotective, and also in the contemporary references, they have anti-anxiety, antidepressant efficacy. And this is the publication with references, especially Brahmi hai, Asgandh hai, Gilo hai, Zafran hai. These are the having the neurocardioprotective effect along with their anti-anxiety effect. This is the Babuna, Tutsia, Ustokhudus, Sandal, Besphage, Amla. Numerous single drugs are available for anti-anxiety, antidepressant along with their cardioprotective, neuroprotective effect. And also Unani system says about the compound formulation. Sir ne bataya mufarrihat, accelerant ka effect cardiotonic bhi hai and neurotonic bhi hai. So the conclusion is that very close relation of between heart and mind. तो सर की जो शायरी है बहुत ही गालिब आती है इस चीज़ पे. तो आप जो सोचते हैं, जो करते हैं, it's a very deep connection. And Unani system, Unani regimens having the promising result to combat these mental health issues. So I hope I convey my message in 10 minutes. Thank you. I acknowledge my DG CCRM and all the team of headquarters. Thank you very much.
Thank you.
It's a very basic conversation, not any innovative things I did actually. It's all literature-based presentation.
Wonderful. Thank you.
Now I call you the chairpersons to kindly felicitate the speaker.
So I'm very happy to see you as a star researcher of council.
She started career in Chennai when I was there.
अच्छा, आपके साथ रही है मैडम. Very enthusiastic.
She was the first doctor who made me by putting.
So can we have a group photograph? Please,
Sure,
we can have a
sure.
group photograph with all the speakers, and then we can proceed for lunch. We're already too late because we have to start another session at 2.
We are taking more time between you and lunch.
It's already 15 minutes. We just have 15 minutes left. Lunch.
Can you move to the court? So what?
I think should we वो क्या करें? अच्छा फोटो लेने आ जाए.
हाँ, बिल्कुल.
सफदर इसको लेने ओके बैग वैग है शायद.
हाँ, बैग
पैक करवा दीजिए.
बिल्कुल.
पैक करवा दीजिए.
इधर आ जाइए, लेना चाह रहे हैं.
आइए सर. आइए. बैग पैक करवा दीजिए क्योंकि ऐसा ना हो खा दो.
कल आप भी नहीं थे, पता लगा कि ऑल्टरनेट आपका रख रखा है. अच्छा, बैग भी है. अरे थैंक यू.
हाँ तो ये अदरवाइज हाउ कैन कैरी दिस.
As I informed, there will be a little change in sequence because one of our speakers is having a little difficulty transferring the file. So we'll start the session, as we are already running short of time. We'll start with Dr. M. Shehryar from School of Pharmaceutical Education and Research, Jamia Hamdard, New Delhi. He will be giving us a talk on development and preclinical investigations of the antioxidant and anti-cancer properties of a Unani formulation in So we'll right away begin with the talk. Dr. Shehryar, please. आपने दे दिया था Yes. We have to take. After lunch, it is good.
So very good afternoon to all. I am thankful to organizer for giving me a chance to discuss the project, the outcome of the project which was awarded to our team at Jamia Hamdard. The project has almost completed. We are presenting here the maximum data. However, due to certain reason, the complete data is not being presented here, and I know that the time limitations are there. This is a huge one, but I will only try to restrain myself to only the particular points which are important. Because if I go, it is just like Tarawih, but the Tarawih can be finished in the overnight also. So the same way I will try to finish, because the timeline, whatever has been assigned, that is comparatively very compressed. So the topic of my talk is the development and the preclinical investigation of the antioxidant and anti-cancer properties of an Unani formulation which has been developed in our lab for the protection from the hepatocellular carcinoma. Please, next slide. 8 minutes. So these are the contents which I am supposed to cover quickly. So please, next slide. I will not go in detail for many things because the hepatocellular carcinoma is one of the major cause of the death, and there are many medicines available in the Unani, but we have tried to use various different combinations. Based on that, we have prepared a formulation in which, the next slide please, we have chosen initially 18 medicines. So initially we took 18 medicines, and each medicine was distributed into 3 groups. Group 1, Group 2 and Group 3, accordingly the 6 medicines were taken, and the first group was tested for the antioxidant property of those HepG2 cancer cell activity that is available in the Unani literature. So we had tried to find out the hepatoprotective property using the cell line, HepG2 cell line. The second group was also comprises of the other 6 drugs which was tested for the hepatoprotective property after developing the hepatocellular carcinoma into the Wistar rat. And the third group, which was also comprising of the 6 medicine which was tested for the antioxidant. The goal of this target was to find out the drugs from each group which are more potent, and afterward they are mixed together to make a murakkab murakkab, and initially we have prepared the murakkab, the majun, and afterward we have also prepared the course also. Both kind of the preparations have been, and that has been presented here. So these are the various drugs, the actual picture. The methodology, we have tried two ways. One is the aqueous extract, and the second was the hydroalcoholic extract. Both ways the usual procedure was used. I will not go in detail because everybody is doing in such kind of work. So we have carried out the aqueous extract and as well as the methanolic, and these are the compound which we have isolated. Then we had carried out the phytochemical screening, in which we have found the various parameters like flavonoids, alkaloids. All these things were tested by using the standard procedure. Then the first group, which was comprises of the Kalonji, Devdar, Balela, Baladur, as mentioned in the slide, and we carried out the in vitro cell line activity using the HepG2 cell line, and all these extracts were used, and sorafenib was used as a standard drug, and based on that we found that the Kalonji was having the most potent activity, followed by Devdar and the Balela. These three medicines were selected out of this group, which was further used for the preparation of the murakkab. These are the IC50s of all these compounds, which was not very prominent or very close to sorafenib, which is a standard drug available, that is not the herbal drug, that is a synthetic medicine being used for the treatment of the hepatocellular carcinoma, but these medicines having the several side effects, that's why the need of the herbal medicine is growing very fast. So these three, Kalonji, Balela and these things were shortlisted from this, and these are the data, comparative data, graphical representation. And this is also the summary of the graphical representation here. Then we took the second group, in which, as I mentioned, the 6 drugs were taken, and these were tested. Initially the animal, with star rat, were chosen, the 6 in each group. Based on the ANOVA analysis, the groups were made, and the hepatocellular carcinoma was developed into the liver by using the suitable reagent, thiocetamide and other things which have been mentioned, and this study was carried out for 2 months period. The first month was the development, and the second month was the only observation period. This is the protocol, and the results of these data have been shown, in which the drugs which have been mentioned in the group 1, which was the normal control, toxic control, which was only administered the toxicants, whereas the group 3 as group 7 has been given the various medicines or the 6 herbs extract, and the final was the standard, that was again sorafenib. The data has also been presented in this case. If you these are the graphical representation of all these, out of which we found that effect of the aqueous extract of the kasni, jamun, aftimun, zard, which is the aloe vera, and mastaki and karanfal of liver function test, and we have tested the SGOT, SGPT, as well as the alkaline phosphate, as well as the other parameters which are responsible for the damage of the damage and recovery of the liver. The histopathology activity was also carried out, in which we can see in the B, the cancer was developed, which was very much evident. Then we have carried out the test, and we can see E and H and I. These are the tests, histopathology of the molecule which we have already tested, and we found that is a great recovery in all these groups were found, and these medicines were further chosen for the formation of the next formulation. These are the details which we have mentioned just previously slide, that is the C and E and G was found to be more potent of that. The third group was comprising of the ashwagandha, giloy, amla, adrak and all aslosus, and the antioxidant activity was carried out by using the ascorbic acid and a standard 96 well plate method was used, DPPH method, and our methodology was used here, and the concentration used in this case was 100 to 500 microliter. This is the image. These are the data which was obtained based on that. These are the graphical representation of the data, and based on that finally we shortlisted these medicine for the formation of the our murakkab as well as the course. Kalonji, Kashnar, Devdar from the group 1, Kasni, Aftimun and Karanfal from the group number 2, Amla, Chichada and Giloy from the group number 3. Further, we had carried out all 3 activities repeatedly, individually as well as for the formulation. For this reason, we have also carried out the total phenolic content, and total flavonoid contents were also tested by using the standard protocol, and data is presented here. This is for the gallic acid was used for the total phenolic content as a standard, and for the total flavonoid content, quercetin was used as a standard, and all these parameters show the good quantity of the total phenolic content in the aqueous extract. Not the same level was found into the methanolic extract. We are just wanted to compare whether all the active ingredients are being isolated in the aqueous or the hydroalcoholic. So we found that several important ingredients which could not be isolated in the ethanolic extract could easily be isolated in the aqueous extract, and these are very much useful because most of the formulation in the Unani are based on the aqueous because of the religious issue. So this point has to be considered, because after that we can isolate the active constituents by using the alcohol, but ultimately finally we can evaporate off. So we tried to use the aqueous extract because of the religious constraint, and we found that the phenolic and the flavonoidal content were more into the aqueous extract. And after that we carried out the percentage growth inhibition of the cancer cell line using Hg2 cell line of the selected molecules one again, as well as the formulation, aqueous formulation and the metholic formulation, as well as the sorafenib, which was used as a standard. If you see, the results are very close to aqueous as well as the sorafenib. Methanolic is not far behind, but still the aqueous extract was having almost the same activity as the sorafenib. These are the graphical representation of all these parameters. And then we had carried out the group 4, which we are talking about. That is a formulation which we have prepared out of the 3 each from each group. That is 9 compound are contained here. DBPH activity of all individual compounds were carried out at different concentration, as well as the aqueous extract, as well as the methanolic extract, using the ascorbic acid as a standard. And in this case also, if you see, we could find the better antioxidant activity at 500 microliter concentration with the aqueous extraction rather than the methanolic. Then this is the graphical representation. These are the all different graphs which we have obtained. Then we had carried out the animal activity by using the different concentration of the, because everything is not possible because there was a limitation of the animal procurement. So what we did, we had prepared a formulation and we used different concentration. 50, if you see, we started with the 25, 50, 75, 100, 125 and 150. We took these concentration for the aqueous extract, and we found that after 100 milligram per kg, the 125 and 150, the plateau was obtained. That the maximum activity was observed in the aqueous extract at 100 milligram. So the same we have chosen for the methanolic extract also. And the final result was also promising that the aqueous extract was far better than the hydroalcoholic extract or the methanolic extract of that. And again, the standard was used as a sorafenib in this case. So this is the various parameters which are responsible for the growth of the tumor growth as well as the cancerous growth. That is the glutathione transferase, glutathione peroxidase, SOD basically you can say collectively the oxidative stress is denoting, glutathione reductase, superoxidized dimutase and catalase. All these things, if you again see the 100 milligram that was having 47.67, whereas the treated group, that is the sorafenib, 47.89, which was very closely related to each other, although in this case the methanolic extract was having quite lesser than that. These are the graphical representation of all these things. And then we had carried out the animal activity again. These are the bilirubin parameter, SGOT, SGPT, as well as the alkaline phosphate and total protein. All these things, again the highlighted portion you can see, these are the potent molecules which are very much comparable to the standard sorafenib. These are the graphical representation of all these. This is the liver. The first one is the normal. The second one is the after treatment. You can see the growth of the tumor, and the other groups which you can see the recovery in the case of C, E and I. This is the section histopathology. The recovery you can see in case of the E, H and I, there is a very good recovery, as well as J, in which we can say almost the complete recovery of the tumor can be observed by the histopathological studies. This is the representation of that. So what we have concluded in this case, that when the liver was infected with the, when the hepatocellular carcinoma was induced, at that time all these parameters was down, GST, GPX, GR, SOD and catalase were down, as well as the ALT, ASP, ALP, bilirubin, albumin, albumin, all were increasing. But after the treatment of the aqueous extract formulation, we found that these levels, GST, GPX, GR, SOD and all these parameters were become normal or almost normal, and the other harmful parameters like SGAT, SGPT, alkaline phosphatase and other things were become normal. So, and one more thing, this is the important thing. After performing all these data, we had compared two important things which we came out, that we had compared aqueous with the hydroalcoholic, and we found the result are very promising in case of aqueous. To justify our results, we carried out, because we are integrating the thing that with the theme, that we carried out the molecular docking also. Molecular docking, because we found, initially we found the main phenolic and flavonoid contents from the plant, we isolated, and we carried out the docking study by using the PDB, that is a 6CV9C, and we found that the higher the negative value, better the result. So in this case, quercetin, which is obtained from the giloy, was having the maximum potential, that is minus 16.4, which is very much better than the sorafenib. So this parameter, and these are the various graphical representation which is showing the binding of the different alanine various proteins and the amino acids, and in this case we can see sorafenib is having minus 7.9, whereas the taxifloine was having minus 8.1. These are the important parameters which are present in the our drug which we have shortlisted. So fortunately, these data is also supporting whatever data we have found after performing all these studies, and this is supported by the modern techniques also, that is a molecular docking using the autodock methodology. Based on that, the first group was comprising of the Kalonji, Kachnar, Devdar, and second group Kasni, Afti, Moon, Karanfal. Third was the Amla, Chirchita, and the Giloy. All these things were mixed together, and Muhafiza Jigar and Hub Muhafiza Jigar Majun, as well as the hub was prepared, which has been presented here for just for the sample, and this is having very good potential. And I believe these are the review and the research article published outcome of this project, which has been granted by the CCRUM. These are the various conferences the paper has been presented there, and this is the image of the preparation which I have presented here, and this is the group who had worked. The project was carried out by myself and the research scholar Akram and Dr. Muhammad Noman Qasmi Saab, and the research group of my lab that has been presented there, and these are the reference. So thank you very much for my side. If there is any question, you are welcome to ask. Sir. Afterward. Okay, okay. Thank you.
The questions can be taken during tea. Special thanks for finishing on time, because we are already running very late. The studies on time as well as the presentation on time. Now we move forward with the next lecture. We have with us Dr. Saif Ahmed, who is Associate Professor in Translation Neuroscience, Neurosurgery Department, Barrow Neurological Institute, USA. He will be presenting his talk on role of 3-acetyl-11 keto-beta boswellic acid, a derivative of Kundur Boswellia serrata in traumatic brain injury. Sir, please.
Well, thank you so much, and it's really a great honor to be here, because in very short notice I was invited by CCRUM PG, Dr. Zahir and Dr. Manullah. And I'm really thankful to CCRUM and DG of CCR, Dr. Zahir. So I traveled too far. In 4 days, I'm just traveling from Phoenix, Arizona to, here Delhi. So a bit tired, but I was so interested to be here. And today, I'm going to talk about one of the plants and its derivative called boswellic acid. But before that, why I am here, I would like to just give a brief introduction about myself and how I started my research. So, and it's really it's an honor that my PhD supervisor, Professor M.Z. Abdeen, is here from Hamdard University. He especially, came to attend this session for me. He likes me very much, I guess. So, this is Saif, and I received my Master in Organic Chemistry from Ruhelkhan University, Bareilly. After that, I moved in Delhi to pursue my PhD. I stayed 6 months in JNU, where I met with several research scholars, and that was an amazing, time for me. And then I moved in Jamia Hamdard and met with Professor Abdeen, and he was so generous. He enrolled me as a PhD student, and that time he received a project funded by the CCRUM. And I got selected as a senior research fellow on that project. And my job was to standardize the active ingredients from 2 medicinal plants, which are very important in the Unani system of medicine. And they are called as Ammi Majus, locally Atrilal, and Sorelia coralifolia, we call as a Babchi. And both plants are being used to develop the herbal formulation to treat vitiligo or leukoderma, the white patches develop. So my job was to cultivate those 2 plants in the herbal garden and collect seeds and stem and leaf. And because the job was to enhance the active ingredients from any part of the plant. So I did my job, and we completed the project successfully, submitted to CCRUM. And then I moved forward. I was interested in the neuroscience, and I got lucky. I got the offer from University of Massachusetts Medical School, and I moved there. Since then, this is my journey. Since 19 years, I'm in the United States. I'm a citizen of the United States, and I have a lab where I am working on the brain stroke and dementia. So this is not my main work. This is the side work because I'm interested on natural product. So I wanted to continue the work, and you must be aware about the Boswellia serrata, right? The plants.
We have all the markers, and we have exporting and from Hyderabad, maybe tons. Okay? Proceed.
Anyway, yeah. How can I move forward?
Breaking the sequence of the, I'm really sorry for breaking the sequence of the presentation, but we have with us Professor Azad Khan from Bangladesh. He is a chairperson for this session, and he was busy in some session downstairs. So he is joining us as a chair. Sir, please have a seat on the dais. You can continue.
Oh, thank you. So today I'm going to show you some of my research which I did in my lab by using this active ingredient. But before that, because I live in Arizona, Phoenix. So Arizona, Phoenix is a beautiful state, and it's famous for the saguaro cactus. It's like a 10 to 20, 30 feet long. And, if you cannot cut this cactus, you will be in jail. So Arizona is famous. And if you see this kind of cactus, means this is from Phoenix, Arizona. This is the Grand Canyon, the picture. World famous Grand Canyon. People from all over the world, they come to see this big, I say it's a gadha, big, but it's very famous and very close where I live. This is my institute, Barrow Neurological Institute, comes under St. Joseph Hospital and Medical Center. And every year, we are recognized as a #1 in neurological, research and neurosurgery. So across the, all USA universities, they ranked us #1 because mainly we are focusing only in the brain research, and we have a hospital. So we have only one department called Translational Neuroscience for the basic scientist. So let's discuss, before moving forward, let's discuss the global market of the herbal medicine. The Fortune Business Insight says that the market was valued at USD $233 billion. What happened? Sorry for the interruption. All right. So I was talking about the herbal market globally. So what it says that by 2032, the market will increase by USD $437 billion. So we can imagine how much potential we have in herbal medicine globally. You know that in US herbal market, this time the USA market, you can go to any pharmacy or grocery store, you can get the over-the-counter herbal drugs. One example I am giving that, like a curcumin. They are selling the curcumin, and we have been using since ancient time in our food, and we know that curcumin has the potential as anti-inflammatory, And there is a scientist named Bharat B. Agarwal. He used to be in Houston, and he used so many plant-derived drugs and published series of the paper to introduce in the U.S. market. And because of him, the USA got the information that curcumin could be useful in the treatment of cancer. So now the Americans, they are buying from the grocery store, pharmacy, it's over the counter, and they are taking as a supplement material, right? So in USA, if you see that in 2022, they have the $11.5 billion market, and it's going to increase 19.7%. Where we are, in 2023, the Indian herbal products market was valued at around $60 billion. India's market for medicinal plant and natural product is growing, driven by increasing health awareness, government support, and disposable income. The market expected to reach $110 billion. I'm not going to teach here the marketing thing. I'm just showing how important to know that how much potential we have in herbal medicine, regardless it's in Unani medicine or in the Ayurveda or any naturopathy. You need to understand, right? So why I selected this plant? I'm not working, this is not my main work. I'm working on complement signaling, some genetics, I'm doing the stock research. Since I'm interested in the herbal drug, one of my friend in 2017 from Oman, he applied to me. He wanted to work as a visiting scholar, so I arranged the visa for him. He came from Oman and joined my lab. So I asked him, Dr. Shah, can you suggest something which you can finish within 3 months? Because I do not have any project for you. I do preclinical research, and it takes time to finish. He suggested CEF. I'm working on Agba. So it's a local name, Agba. And we called Boswellia serrata, which is known as Kundur in the Unani system of medicine. Agba has several ingredients, but boswellic acid is the main ingredient, which has like a very good anti-inflammatory properties. This is the botanical origin. I'm not going there. And we also call this plant as a shalaki in Sanskrit, right? This is the plant. You can go to the hilly area, you can find the Boswellia serrata over there. And then this is the gums, resin, which you collect from the plant. And interestingly, we all know that, Loban, right? Sometimes you see people come and they do, right? So when I was kid, I saw this kind of thing. I didn't know that. It's like a Boswellia serrata, but it's Loban. Okay, so Agba, Loban, or Boswellic acid, same. Okay, so because I got interested, when Shah Alam told me, I got interested on this drug, and we purchased from Sigma, and we did some in vitro work. So before that, I searched the literature. I wanted to see, what kind of research, the other scientists have done. In the cancer, they reported that it's like a protective and inflammatory disorder like asthma, ulcer, and eczema, psoriasis, and metabolic disorder like diabetes and ischemic reperfusion. That's the style keto. I don't know, it's not working. But that's the structure. And you see the Boswellia, that product you can get in USA. They are selling our product there, right? Anyway. So I'm just showing you that the worldwide publications in Agba research. So see, look at that. They have published in Alzheimer's disease, they have published in cancer, they have published in several cerebral vascular diseases. And these are some very good publications. First one, Bharat B. Agrawal, he showed in cancer. And then other groups, they publish in different, diseases. I got interested because I got this last one, it got published from China. And they showed that the Agba treatment is reducing the infarction in stroke mice. So I became very interested. Okay, but the problem is, you cannot be leader if you are working on diabetes, several people are working on diabetes, you have to show something, something new, novel thing, right? So I started, thinking about it, and the first thing we did with Shah Alam, we did some in vitro work. And we had a endothelial cell line called BEN3 cell, and we did OGD, the mimic, the model, right? A stroke model. You put the cell inside the chamber, reduce the oxygen level like 1%, it creates the hypoxia. And it's a very easy, thing to do. And we did some experiment and published this in Neuromolecular Medicine in 2019. And these are some data, like we checked some blood-brain barrier integrity, the ZO1, the marker, and occlurin, both are the marker for the BBB. And this is like a hypothesis. In any research, you have to think that how you are gonna move forward, how can you proceed with your idea, right? So this was the idea, and we published this paper, and then I moved forward. So let's talk about why I selected the traumatic brain injury. You will be amazed to see the data of India. Look at that. A traumatic brain injury is an injury to the brain caused by an external force. Let me tell you, no one is working on TBI worldwide. Because I searched the literature, I found that. I took this opportunity, and I thought that I have a facility, so let's start this thing, right? So a traumatic brain injury is an injury to the brain caused by an external force, such as a blow to the head. TBIs can range from mild to severe and can cause physical and mental challenges. So think, if somebody is having a stroke, or somebody is having like a TBI is acute phase, right? You cannot give a drug before any event, because we don't know when I'm going to have the stroke, right? So everything you have to manage like a post-stroke, like a post-TBI, right? So this is common cause of traumatic brain injury, the fall, accident, sports, and war theater where the army is fighting and they have exposure for this event. And this is like a mild TBI where you can survive and you can recover quickly, weeks or in months, you'll be recovered, and then moderate, and then severe TBI. In 2021, there were approximately 37.93 million prevalent cases of TBI worldwide. Each year, there are about 500 to 800 new cases of TBI per 100,000, 1 lakh people, according to multiple studies from the USA and New Zealand. According to statistics, in 2023, there were an estimated 68,000 deaths in the United States due to traumatic brain injury. In United States, because of the motor vehicle accident, because of the army things, a lot of things happen. Like household things, fighting, right? Domestic violence. So according to the available data, India experiences a high burden of traumatic brain injury cases, with estimates suggesting that around 1.5 to 2 million people suffer TBIs annually. That's a very serious issue, resulting in approximately 1 million deaths each year from TBI in India itself. The majority of these injuries are caused by road traffic accident, because we do not have that kind of control here in India. Everyone is using like a main road, car is coming and you hit the bikers, right? So 60% cases in TBI. My point is, we have a lot of potential in the Unani system of medicine to develop something which you can manage post TBI, because it's an acute phase. You need a allopathic medicine to treat as a first aid. After that, if the person survives, you need to manage, because that TBI leads to the dementia after some time. You can develop the Alzheimer's disease, right? So look at that, this picture, types of traumatic brain injury. We have a direct impact injury, we have a acceleration and displacement injury, and blast injury. Blast injury means when you are fighting, if you are in army, you'll be exposed. Okay, this is the MRI picture I took from one of the publication by Kim et al. Look at that, the arrow, you see, the white matter damage. It's a mild TBI. Even in mild TBI, you see the white matter damage. And if you have the white matter damage, means you will have the hippocampus atrophy. The hippocampus, the memory, right? If you have a hippocampus atrophy, means you are losing the neurons, and you will be developing the Alzheimer's disease after some time if you are not going to get a proper treatment. And this is from my hospital in 2018. Due to the domestic violence, one woman came and they did the MRI, and you can see the normal picture and the TBI picture. So these are some models. Okay, so for any preclinical research, you need a good preclinical model, right? The animal model. Either you do the in vitro, where you test the drugs, but you have to, when you want to move forward for the clinical testing, you have to do some preclinical first, right? So I use one model, weight drop model, kind of, and for 7 days, we hit the brain for 5 to 7 days to develop the TBI. And how you check? That's my surgical suite. So I have the instrument where you can measure the blood flow, and I think this is a very good instrument. I think government has a lot of funding. In any, each and every laboratory, we should have this instrument, laser speckle, where you can measure the blood flow for the small animal. So look at that, the normal, left side, the sham and the TBI, you see the blood flow drop, right? And then how you check that after TBI? You use some marker, NUN is very famous marker, and you can see that the NUN is decreasing. So that's the symptom, like it means you have a brain damage. This is the big picture. You see the hippocampus atrophy, normal hippocampus, and the one, is inflamed, and it will, the neurons, over the time, they decrease. All right, so then, I thought, what should I do by using this drug? So I designed this idea, traumatic brain injury, and these are the marker complement, C3R, microglia, cytokines, and neutrophil. Right? All these markers are related with the inflammation. So the first thing what I did, because I am interested on the inflammatory mechanism, we check this. This is simple immunohistochemistry. I check the IBA1, which is a marker for activated microglia. If you look at that, like a sham group TBI and TBI with AGBA. AGBA significantly reduced the activation of the microglia. And then this is another proof with the Western blotting. And you can see the expression was down, protein expression was down in the AGBA treated group. And this is the GFAP, which is another astrocytes, and we show when there is inflammation and it got reduced. And then check the ELISA, TNF alpha. These are like a known markers. If you start working on inflammatory diseases, you need to check these markers. And then I move forward with the flow cytometry because I was interested like what microglia is doing. The microglia is very important. If you are a normal, if I do not have any TBI or any brain issue, the microglia will be like in the resting mode. And once you have some inflammation or damage in the brain, they get activated because they want to fight with the foreign subjects. And then they start releasing the cytokines and other chemokines. And if they are like a remain activated, means there will be a autoimmune issue. Oh, sorry. So I did the immunofluorescence, same thing, CD68, the marker for macrophages, it got reduced there. I do not have a time, so can't explain everything. This is Ly6G, the neutrophil, marker. I check the neutrophil marker because my idea is that like after TBI, there will be blood-brain barrier damage. It will be compromised during the event. And these, inflammatory cells, is going inside into the brain. And this is like a netosis markers where, because my idea is to focus on the neutrophil infiltration. So these are interrelated. I'm not going to, you gave me just 1 minute. Okay, so we did some Western blotting where we checked some, some markers, C3R and occludin, which is the blood-brain barrier marker, and some C3R protein with ELISA, occludin. And then last, we did tunnel assay to check the cell death. Okay, so because I talk about the cerebral blood flow, so I wanted to see what happened once we give the AGBA treatment to the mice, and you can see that the blood flow was increased. And this is one of the like a behavior, data, novel object test to check that whether mice have a dementia or not. Okay, now this is the important slide because I am developing this project for the USA military where you can get a very good funding. So my idea is to make some herbal formulation which after the TBI, which we can give like a vapor through the nasal. So I am developing this and I'm going to submit this grant again to get from DOD funding. And then we can check a lot of markers. So these are some, drug from the Unani system of medicine. Why I'm showing here? Because we need to manage the post-TBI, event. So these, drugs, they enhance the memory power, they enhance your immune system, and they are very good. Some people told me that it's fantastic. And believe me, some of my friends from USA, they always ask me, say, if you are traveling, can you get some Unani drug for me? But it is like a very, very hard. If you land there, they check your bag and they just take it out. So, conclusion, this study provides novel evidences in support of neuroprotective role for AGBA in post-TBI complications. Future studies aimed at developing AGBA as a therapeutic target for this disease are underway. acknowledgement. So I am very much thankful to Dr. Akhtar, who is working with me, Sudhanshu Raikwar, Jessica, Abdul, Cynthia, Caris in my lab. And I have some collaborators, Andrew Abdukre, who is a neurosurgeon, Kanchan Ruchira Jha, she is a neurologist, and Michael Water is the chief of stroke, Huda, Abdullah, Ian, Elliot, a lot of people. And this is a picture of Andrew, Michael, and Jha. Funding source I have from Barrow, Arizona Alzheimer, Arizona Biomedical. Recently I got a R1 from NIH, which is active now. I have 2 active grants from DOD. And thank you. If you have any question, please ask. Oh, okay. It's not going back. Okay. Resin. Yeah.
India, Madhya Pradesh is the topmost state is supplying tons of with this material. And most important, you will get the very good, beautiful,
yeah,
beautiful new and that advanced publication. But there is a lot of Unani, there is a lot of plants, herbs are there for the neurology. So if you are taking the Akim's advice, if you are doing this for the interest of the country, so we are very, because you are a good model, and especially for the who are not workers. That is the only we want to give to our students.
Thank you. Yeah. So my main purpose was to show that in the Unani system of medicine, we have a great potential. We have a lot of drugs. And if we can validate, then we can go to the international market to show that, hey, our ancient system is far better than your system. That's my idea.
You have a model, you have support for Indian people, and you contribute for the Indian society. Environment is most important. If you are doing these things, it is a great contribution for the.
Thank you, sir.
Thank you, Dr. Saif, for that informative talk. Thank you so much. Next, as we move forward, I just want to clarify, we are very short of time, and we have, with reducing the time still further, we have 5 minutes plus 2, 5 plus 2. So with that information, I call Dr. Mariam Sarwat from Amity Institute of Pharmacy, Amity University. She'll be giving her talk on evaluation of the anti-cancer potential of Unani formulation Dul Kurkum. She's again one of our, she's been doing research in collaboration, and she's getting us wonderful results from Dul Kurkum, and she's publishing it in very nice journals. So with these words, I call upon her.
Thank you. Yeah, sure. Assalamu alaikum and good afternoon, everyone. So we have heard very nice presentations from Professor Shahryar and Dr. Saif. They both are from my alma mater, Jamia Hamdard. I did PhD from Jamia Hamdard, and from the past 14 years, I am at Amity University as a professor. And this work which I am presenting here is funded by CCRUM, Ministry of Ayush. I started this work in 2018. So, and I am still continuing it. So it is like my baby. I am very much passionate about it. So next slide. I have to do. Yeah. So this work has, it is, you can say that very close to my heart, because we have worked during the COVID time and all the labs were closed, and these are my research scholars who are working very hardly during that time. So all the credit goes to them, Dr. Sajida, Dr. Anchal, and Minakshi. And we have published 6 international papers out of this project, and still work is going on in collaboration with different institutes internationally. So we all are scientists here. We know that our all story begins with certain story behind it. There is also a story when I started this work, but this story is a sad one because my mother died of liver cancer in 2013, and at that time I thought that let me utilize my life and somewhere to help mankind for eradication of cancer. And then we discussed with CCRUM, and then we have started this work on liver cancer. We all know that are the intricacies of cancer, because most of the people here must be having some certain family member who is suffering for this cancer, or maybe died of cancer, because it is such a deadly disease. So I'm not going into detail about how deadly the cancer is, and we all know that various treatment strategies are available, but all have their own limitations. And that is why we all are focusing about complementary and alternative medicine, and WHO is also focusing on that. And Unani medicine is one of the pioneer in this, and it is not only in India, it is in China, Egypt, Iraq, Persia, and Syria as well. So my work is that we have made the drug in-house from these 7 plants. And although the Unani, this drug is very much famous for spleen disorders, liver dysfunction, and already practitioners are using it, but yes, no research has been conducted to validate its use in HCC, and that is what we have done. So here is a summary slide where I am giving that we have done the in vivo studies as well as in vitro studies. You can see the detail in the subsequent slides. We have followed the Unani pharmacopoeia for this work, and then we have made the drug from the scratch, and then we validated it, that whether all the ingredients, all the secondary metabolites are present or not in this drug through HPTLC. So these are the secondary metabolites: p-coumaric acid, cinnamaldehyde, citral, crocin, gugulstrone, isovaleric acid, and dehydrocastoslactone, which are present in all the plant components which are being utilized for this, the Dul Kurkum preparation. So we found through HPTLC fingerprinting that all of them are present, and then we did the certain other pharmacognostic evaluation, and we published this paper in 3 Impact Factor. Then we wanted to see that whether DUK, the Dul Kurkum, we call it as DUK. DUK is more potent than saffron. Why we have done this? Because saffron is the most important ingredient of the Dul Kurkum. That is why the name of saffron is derived from that kurkum. So we compared that. We took the saffron extract as well as DUK, and then we checked on the cancer cell lines as well as primary hepatocytes. So this is our result, and we found that the DUK, when we are using DUK, then we are using in micrograms, and it is showing the similar, more potent effect than the saffron extract. Saffron extract is being used in milligram quantities. And as migratory effect is the more important feature of HCC. So we wanted to see that what is the effect of DUK on cell migration, whether it is inhibiting cell migration or not. And we found that scratch closer, this is a very common assay for in vitro studies we do on cancer cell lines. And we found that DUK is exhibiting a lower propensity for scratch closure, means that it is showing good effect. Then we wanted to see that what is the long-term effect of the Dul Kurkum. And then we did this study for 7 days, colony forming efficiency of DUK, and we found that DUK treatment significantly reduced the number of colonies in a dose-dependent manner. We are increasing the dose of DUK, then it is decreasing the clone formation in Hep3B cells. These are the cancer cells. Then we wanted to see that what is the effect of DUK on cell cycle progression. So we did flow cytometry and FACS analysis, and we have shown that DUK arrests the cell cycle at G2M phase in the Hep3B cells. And this is the most important quality of cancer cells, that whenever we are assessing the anti-cancer activity, we have to see that where the cell cycle is arresting. Then we analyze all the markers for cell cycle through QRT-PCR analysis, and we observe that significant downregulation in the levels of these genes, which are E2F1, c-MYC, and cyclin D and E. So as you know that uncontrolled proliferation and problematic apoptosis and angiogenesis is the most common feature when we talk about cancer cells. So we wanted to see that whether our drug is affecting that also, whether it is inducing apoptosis or not. Through this annexin V PI staining, we have done this. We have labeled our cells with annexin V PI, and then we checked that, and we found that DUK triggered apoptosis at the early and late apoptosis stage, but no necrotic cells has been found. Then we checked that what are the effect on different proteins which are pertaining to this pro-apoptotic markers and anti-apoptotic markers, and we found that DUK treatment causes downregulation of anti-apoptotic proteins. It means that it is further confirmed that apoptosis induction is contributed through the DUK. And DUK also causes significant upregulation of the caspase family genes. Thank you. So when we were through about with our in vitro studies, we followed our experimental data for in vivo assay, and then we used about 48 male Vistarite, and we have divided it into 6 different groups: vehicle control, then induction control, then only drug control, then carcinogen with different doses of DUK. And we found that when we checked the histopathological examination of this, then you can see that in the vehicle control there is a lot of, there is no issues, but when we are doing the induction control, there is nuclear TPA and vacuolization can be seen here in the C part. And when we are treating with different concentration of DUK, then when the concentration of DUK is increasing, then clearing of cytoplasm and nuclear TPA can be seen in the figure D, E, and F. So from this, DUK restrains the morphological and physiological changes in HCC rats. We have seen that. Treatment with DEN and 2AF is known to initiate the cancer within 1 month. This we have seen. Then hair loss reduction and food intake and significant weight loss in the induction control animals are compared to control animals. And these changes were restrained when we have treated with DUK in a dose-dependent manner. When we are increasing the dose, then it is further curing the things. Then we checked what are the serum marker activities in the experimental group, like AST, ALT, and ALP. This is the hallmarks of HCC. Then treatment with DUK showed a significant and dose-dependent fall in the serum marker levels, as you can see in the different groups. In the induction group, they are increasing in the purple section. And when we are giving the DUK in different concentrations, 75, 150, and 300, it is reducing these markers. It means that it is curing the liver. And then we have checked that what is the effect of the oxidative injury, that when the oxidative injury is there, then how it is affecting when DUK is treated with that. So you can see that DUK may attenuate the oxidative injury in HCC bearing rats when we check the MDA, SOD, and CAT levels. So we can discuss that prepared DUK was pharmacognostically and phytochemically standardized using HPTLC with respect to marker constituents present in materials from 7 individual plants. Then DUK exhibited excellent antioxidant activity and significantly reduced the viability of liver cancer cell line, HepG2, Hep3B, and HUH7. These are the 3 cancer cell lines which we have tested, without affecting the viability of parent liver cells. And DUK was effective against DEN-induced HCC model in male Vista rats. So we have concluded that this study reported for the first time that DUK exerts multiple anti-cancer activities in liver cancer cells and HCC-bearing rats. By attenuating, we have also checked all the molecular machinery involved here. So DUK can be a potential formulation for the management of HCC, and that is why this work is going on further, and we are going for the clinical trials. We have already discussed with Apollo Hospital has been ready for this, and the DG CCRM has come to MIT for this collaboration only. So this is not the end of the story, because we wanted to see that what are the actual markers. If it is not saffron, then what are the most important components of DUK? So first we did the molecular docking studies. We have done taken all the bioactive compounds from DUK, and then we docked them with the development, progression, and suppression markers of HCC. So we found that 3 important components, Z-gugulistone, dihydrocostoslactone, and crocin, are doing much better than the other 4. And we validated our study through the MD simulation. And then we found and then we did the in vitro investigation and found that Z-gugulistone was the major one, which is affecting the cancer cells in a much greater manner. So we did further studies with Z-gugulistone, and this is the paper which we have published in Molecules and Frontiers in Pharmacology. So these are a couple of publications which we have published from that. One book we have published. This all thanks to CCRM for giving me the grant for all this work and hiring the student project staff. Thank you. This is my research team at MIT University, Noida. And this is my research lab, which I've developed from some of the funding and some other funding, which we have got from different institutes like DBT, DST, CCRM, DST, SERB, again CCRM, and ICMR. So any questions and suggestions?
We can keep the discussions for IT.
Thank you.
Thank you, Dr. Mariam. just like Dul Kurkum, we all will agree that there are so many formulations which are still unexplored. And we have a bunch of so many scientists sitting here. A personal request that give us nice, good projects so that we can actually come up with evidence-based results, outcomes for our formulations. Moving forward, we have Dr. Jasbir Kaur from Ocular Biochemistry, Dr. RP Center for Ophthalmic Studies Sciences, AIMS, New Delhi, and she is presenting her talk on therapeutic potential of Unani formulation in the management of glaucoma, a silent killer of vision. This is again one of our prestigious collaborative projects that we are undertaking. Again, the time limit is 5 plus 2, please. Thank you so much.
Good afternoon. So today I will be presenting one of our collaborated project with CCRMU. We thank CSMU for giving us a good collaboration for us. Slide please. So as you know that in India the blindness is increasing very fast because maybe we are not able to control them out effectively. So in Vision 2020 from Government of India, it was like to approach the control the blindness from all other approaches, like have a multidisciplinary approach to control the blindness. And after the cataract, the blindness is from glaucoma, which we usually call kala motia. Please, slides, please. The kala motia is a silent killer of vision. Means like a patient doesn't know that he's or she's losing the eyesight and slowly get deteriorated. So I will focus mainly on the important points what we have got in highlights in our results. When we do any research, we should focus like how the drug will effective in a patient, means what is causing the disease. So the two major sites which are getting affected in kala motia or glaucoma are retinal ganglion cells and tubercular meshwork. This tubercular meshwork means we have glaucoma of two types, open angle and closer angle. So only we can treat with the drug the open angle, means where the surgery is not required. In closer, the tubercular meshwork get closed, so by laser or surgically we have to open the tubercular meshwork. But in drugs we can have the intraocular pressure increased, we can decrease it by using different medicines and from allopathy and other Ayush medicines also. So the two sites which we have to focus for in glaucoma is your tubercular meshwork. If any drug is effective in those two sites, we can scientifically prove that these drugs will be giving efficacy in potentially for therapeutic, has a therapeutic potential in glaucoma treatment. So please slides. So the major two pathomechanism is your oxidative stress increases in tubercular meshwork and your RG cells dies. So we say in glaucoma, once vision is lost, it's lost, because in RG cells, when it's die, it's not, in allopathically we cannot revive them out. So the vision which is lost in glaucoma or kala motia is irreversible. But here we have tried whether we can prevent them or we can have a reversible process. So what we have seen, if any formulation who has a potential of antioxidant property or neuroprotective, we can try on these two sites, that is tubercular meshwork and ganglion cell sites, from the patient samples and from the cell lines also. Sir, can you give this me here?
It's next
Hmm?
It's next
ये वाला है ना, next on तो आप करिए. So we have chosen one formulation and we have tried on the glaucoma samples from the glaucoma patients. we have tried, first we have seen that whether the formulation which is, are trying having any antioxidant properties also or not, before trying it on the patient samples. So we have tested the extract, aqueous extract for testing for the phenolic content and flavonoids content. We got that they have that antioxidant properties by different methods. I am trying to skip because shortage of time, because we have that different methods to see that the plant extract has antioxidant properties before proceeding towards the patient samples. Yes, our result shows that from the 4 methods that the plant has the antioxidant properties. So what we did it, then we have tried to see the active compounds from LCMS and see the mass spectrum, what is the different correlating with the different important constituents. So important phytoconstituents, we got 18 phytoconstituents actively in our results, LCMS. Then network pharmacology showed that 474 targets has been identified when we have used the different methods to see that, and out of that 32 was related to glaucoma. Out of 32, 2 identical glaucoma genes we found, MOCNC1, which is very much reported in glaucoma patients. So we found that if we are having this formulation, so we are getting the target to important related genes also. And different pathways we are getting related, like MK signaling pathway and HF1 pathway, which are very much related to glaucoma. So when we have done the pharmacology of this networking, we found that this pharmacology has shown that this formulation has the relationship with the glaucoma genes effect. Then what we did it is to see the affinity of this 18 LCMS compounds. We have targeted on the docking method. We have taken 4 targets which are well reported in glaucoma, and with this 18 phytoconstituents, we found that yes, the affinity was more than in some of the thing like -7, -8.6 we have got. So the affinity is much closer to our 4 targeted genes, which is well reported in glaucoma. If any drugs is effective, that should affect these 4 targets. Next slide, please. So what we did it, then we tried that yes, our formulation is having antioxidant properties. We have got 18 constituents, and that they are showing also on the targeting 4 targets also. So we tried it. We have taken the samples from the patient, glaucoma patients directly from the OT, and prepared the primary culture and seen this extra effect of this drugs formulation on trabecular meshwork and as well as on the RG cell lines. And we have first done the, as usual, the cytotoxicity effect, find out the IC50 and IC30. Then with the standard drugs, we have compared it, like what will be the effect with the standard drugs, xanthine, which we give it. Then we have seen if the drug is dying, like we have from flow cytometry, that what will be the effect. Apoptosis means the natural cell death will be there. So what will be the effect of these drugs on using flow cytometry? We have seen it, and with the 4 different methods. Now the comes is like if we have anything seeing that on the patient samples, we say the cells are live, but cells live doesn't mean that they're functionally active. RG cells has to take the images from to help the image from here to brain, so that we can see vision. So for the vision, we have to have the cell activity, functional activity properly. So our results were showing that the reported literatures for different drugs and all that, they showed that the Unani medicines or Ayush medicines are effective for anti-apoptotic effects, antioxidants. But the thing is whether the functional cellular activity also been retained or not. So we did the potential membrane activity, and in membrane potential activity, we have seen, I'm just skipping the things. We are seeing that the membrane potential activity, we got that the cells are functionally active also. If they are functionally active, then only they can take the signal of vision from to brain, RG cells. So it means that not only the Unani formulations, we have tested this out with the real-time PCR also, and we have seen on different markers also, like TH1 is development of ganglion cells, BRP is involved in transcriptional and axon growth. That is the pathway where the vision is seen from the eyes to brain. Then brain-derived neuroprotective BDF also, it has effect on that. So the 4 targets which we have taken to see our Unani formulation, yes, they are showing a positive effect. By docking also we have proved. So the Unani formulation is significant in increasing these 4 neuroprotective markers. It means it will protect the neurons, RG cells. So these are the different results with mRNA. Then we have complementary our results with the Western blotting also, that what happens at the protein level. Yes, we got that at the protein level also, at the tablet meshwork in RG cells, they are increasing the effect. So in short, if we see that our result shows that the Unani formulation is having a minimum side effects, because the LD50 shows that it is comparable to the standard allopathic drug. And the most important and highlighting thing which we got here is that it not only protecting our 2 important sites, that is tablet meshwork, which is getting affected in glaucoma patients, and RG cells, it is also retaining the functional activity of this, that is membrane potential activity is very important here. So we are not only able to restore the tablet meshwork, that it has antioxidant properties, it has neuroprotective, but it has also showing the functional activity retained. So it means whatever, the next step is whatever neurons we have lost, we say allopathy, it is irreversible. So can we regain them out if we do on a larger? We have done on 48 hours cultures from the patient samples, but if it is given for a prolonged time, can we revive this? What is lost is lost. Can we revise this sentence in glaucoma patients? So can we revise our vision or retain some vision which we have lost it? So that will be the next step. But till now we are hoping very good that at least it is having also the cellular functioning activity here. Thank you. And I think I have stopped within the time limit. Thanks a lot.
Thank you so much. Thank you so much, ma'am. I invite my next speaker, Dr. Mohammad Kamil, Director General, Lotus Holistic Health Institute, UAE, for delivering his talk on history and research trends in Unani medicine and experience sharing. Sir, I request you, I've already requested you, I'll again request you to please.
Thank you. Respected chairpersons, very distinguished guests, colleagues, ladies and gentlemen, very good afternoon. At the outset, I would like to thank Almighty for giving me a chance to be here. I'm thankful to Dr. Zahir Ahmed Saab, the Director CCRU, for the kind invitation as well as the hospitality and the accorded to us. Well, the topic is, with a very brief history, the research trends in Unani medicine, experience sharing. Well, the 9th and 10th centuries have been designated as the golden period of Arabic medicine. With the spread of the Arabic language has a wholesome influence on science with a special reference to the medicine. Arabic medicine or Unani medicine, as the very name indicates, originated in Greece and is based on the teaching of कौन सा switch है साहब इसका? White one? Based on the teaching of Hippocrates, Dioscorides, Galen, Jaber, Rhazes, Ibn Sina, Ibn Battar, and so on. These scholars have contributed a lot for the Unani medicine, and they have written a number of the books spread from a period of 9th to 13th century. Well, Hippocrates, the Greek physician philosopher Hippocrates, who freed the medicine from the realm of superstition and magic and gave it a status of science. It was Hippocrates who described that disease is a natural process and the symptoms are the reactions of the body to the disease. He was the first physician and probably the only one on the list who has who described to take the history of the medicine. I'll not go into detail. Well, he has the Gallen, the pioneer of experimental medicine. He has written 256 books. Gallen has established its base on which the Arab physicians like Ibn Sina, Ibn Baitar, Ibn Nafis, Ibn Khaldun, and many others, they have constructed an imposing edifice. Well, there is an old Arab saying, medicine did not exist before Hippocrates created it, dead before Gallen revived it, scattered before Al-Razi collected it, and incomplete before Ibn Sina completed it. Well, if we see the journey of the Unani medicine, it is started from Greece, Turkey, Iran, Pakistan to India. In India, it was, in the pre-independent India, it was pursued by two families of Unani physicians, the Azizia family of Lucknow, commonly known as Hakims of Jawai Tola, and the second Sharifi family of eminent Hakim Ajmal Khan Sahab. Hakim Ajmal Khan Sahab was one of the founder person of Jamia Millia Islamia. He took great interest in the expansion of Unani medicine, and he built 3 institutions: Central College, Delhi, Hindustani Dawakhana, and the third Ayurveda and Unani College in Delhi, commonly known as the Tibia College, Karol Bagh. In independent India, Hakim Abdul Hamid Sahab has taken a lot of interest in it, and he was the chancellor as well as the founder of Jamia Hamdard, and I have had an opportunity to work with him for a certain period and learned a lot from him. It will out of the place to mention that Central Council for Research in Unani Medicine, which was in 1978, after its establishment as an apex government body for the research in Unani medicine, has contributed a lot for the Unani medicine, and now India has become a part of. In 2022, the World Health Organization has prepared the benchmark for the practice of Unani medicine. Well, above all, the identification of Unani medicine is a difficult task. Nowadays, the closely related medicinal plants, they should be separated on the basis of their minute differences. At this moment, I remember and recall Gallen, who in one of his famous books on anatomical procedures, a text for 1400 years, he advised to his readers, I quote, in order to inspect the drugs, in order to identify the drug, inspect them not once or twice, but frequently, as the twins looks alike to the strangers, but they can be easily distinguished by the friends. So it's a very common practice, and quite a lot number of herbal medicine or Unani medicine have been adulterated with cheap, less potent and spurious plant materials, either posing danger to the public health or they are not so efficacious as expected. I will take, due to the paucity of time, I will take only one example, saffron, that is Crocus sativus, saffron. The dried stigma of Crocus sativus It has got 0.7 to 0.3% of saffron. Besides having refrigerant, tonic, diuretic, and stimulant properties, saffron has anti-inflammatory, antiseptic, as well as aphrodisiac properties, for which it is being incorporated in many of the compound preparations, murakkabat. Since it's a costly ingredient, the adulteration is on its peak. To differentiate between the adulterated and pure, the structure of the stigma, which is slightly expanded in the form of a narrow tubular structure and can be visible even with the hand lens, it plays an important role. The substitution in saffron, you know, marigold flower, safflower. The substitutes, the substances used may be grouped into three categories. The materials that have some external resemblance to saffron, exhausted saffron required by dye and substances added to the saffron. So basically the adulterants are beetroot, pomegranate fiber, red dye fiber. To increase the, you can say, to increase the amount and to reduce the price. Even the style of saffron is being added to the stigma to make the mass, the greater of mass. These all plants, flowers are being added to the saffron. Nowadays, this kurkum is being added to the saffron, and it is available in the market with the name of Indian saffron, Mexican saffron, and American saffron. So one should be cautious about it, and there is no. These are the chemical tests which is provided by United States Pharmacopoeia. I'm not going to read it. These are Food and Drug Administration has given this criteria that these stigmas must be yellow and the foreign organic compounds more than 10%, similarly others. Then the chemical composition of saffron is as follows. This is the proximate analysis for the saffron. So these are the complete tests for the saffron. Sorry. The most prominent compound of saffron is saffronal, crocin, and crocetine. This is the TLC fingerprint of Crocus sativus, showing these four prominent compounds present over it, and this is the structure of compound. The structure of these compounds, and it shows that picrocrocin, which is responsible for taste, saffronal, which is responsible for the fragrance, and saffron, that is, so each compound has got. I'm passing some slides due to the paucity of time. Basically, turmeric is mainly being added, and it is at 7.3.
Please.
Expediting. Yes. I'm just summarizing it. 7.3, and when the different percentage of turmeric is added, it can be easily seen over here. 1%, 3, 5, and 10%, and can be identified. Now, HPTLC fingerprint of the saffron, when we do it, we found the 4 compounds, 4 bands, 1.7, 0.1, 0.17, 0.23, and 0.47. And this is the specific HPTLC. This is the specific HPTLC fingerprinting of saffron. And since the standardization of saffron has been done on this basis, then the market sample have been taken and extracted. There are 104 samples have been tested from the market, and out of them 60 contains the HPTLC fingerprint, and it is specific to it, is specific of the HPLC fingerprint of saffron, as well as stable for more than 6 years at room temperature. However, 32 were not resembling with the HPTLC fingerprint of saffron, and that has been marked. These are the references, and with this, I'm thankful to Dr. Zahir Ahmed Saab, Director of Ayush, for the CCRUM Ayush, for the kind invitation and hospitality. Thanks, Aralto, for listening and concentration. I'm sorry that due to the paucity of time, I have to skip a lot. Thank you very much. Thanks for your kind concentration.
Thank you so much, sir.
Khush
So my happiness is relative. Thank you so much, sir. Now I invite Professor Arshia Sultana again with the request to keep your presentation as short as possible. I have an important announcement to make. As Dr. Sunchu Glory Swarupa, she has to leave for a meeting. We'll have a felicitation for her. We'll have a felicitation. We have a memento. I request Dr. Amir Jahan and Professor Azad Khan to please felicitate her with the memento. Dr. Swarupa.
What do I do?
Swarupa.
Yes.
Because I deeply regret that we have to cut that time so short, but the Joint Secretary and the advisor, sir, have already arrived, and we have to have our valedictory session at 4.
You have to present to me.
I have to present to you.
Thank you so much, ma'am, for joining us. Now, please.
Hello. Hello, thank you. At the outside, I'd like to thank the organizers, especially DG sir and their whole team for giving this opportunity to present myself on this diverse gathering. So with this, I will not waste my time. So my topic is Unani medicine as a therapeutic approach for premenstrual syndrome, a systematic review and meta-analysis. So we all know premenstrual syndrome. It is seen in luteal phase and it affects 20 to 30% of reproductive age women. And the symptoms are physical symptoms and emotional symptoms. Like physical symptoms are bloating, headache, low tolerance to heat, noise or light, and emotional symptoms are irritability, depression, anxiety, etc. So here, we can see, I think so the slides. So here we see that here what I'm going to present is level of evidence that is meta-analysis and systemic review, and we are able to see that in Unani classical literature, there are many medicinal plants which are useful in premenstrual syndrome. So with this, the objective was to explore RCTs on PMS for systematic review, meta-analysis and risk of bias assessment, and to provide objective data for efficacy and safety of Unani medicine in nutritional supplements in relieving premenstrual symptoms. So with this, the methodology was first to develop a protocol, then register in Prospero, then complete literature search, data extraction, outcomes, risk bias and quality assessment, strategy for data analysis and measure of effect, analysis of subgroups and subsets, and reporting the results. So the study design was systematic review and meta-analysis. The duration of the study was June 10, 2022 to 8th October 2022, and the study was registered in Prospero, New York. The inclusion criteria for this study were reproductive age women with regular menstrual cycle, diagnosed PMS with the help of DSM, DSR or ACOG criteria, or other diagnostic scale using either Unani medicine or herbal medicine. And at least 2 cycles of interventions were given to the patients, and the control can be placebo or any conventional medicine. And the papers which were selected were only of English, other languages were excluded in this. The exclusion criteria were the studies which were having systematic diseases, non-psychiatric patients, pregnancy or lactation, other routes of administration, because we have only taken oral route of administration here, and the experiment were limited to humans. And we excluded non-RCTs, quasi-RCTs, case reports and others, and the studies which were inadequate. So the data source and how we extracted, data exploration was done through Google Scholar, PubMed, Scopus and Prospero. We collected all the papers from 2008 to 2022, and we focused on RCT on PMS with medical subject keywords like premenstrual syndrome, nutritional supplement, herbal or Unani medicine, and premenstrual syndrome. To extract the data and to remove the duplicates and others, we have used an online software called as Vigyan to identify the RCTs. Then the data was extracted. First we saw the titles, then we saw the abstracts and keywords. Then when the title and abstract was okay, then we have seen the full length of the paper. 4 researchers independently analyzed and extracted the data, and post-treatment data, then we followed the PRISMA and consort statement to include RCT, and we did meta-analysis. The outcome was premenstrual symptom screening tool, PMTS and DSR. And the secondary outcome was subscales and adverse effects. Then risk of bias was done by Cochrane risk. Then we followed statistical analysis, which is used for meta-analysis. I'm not going in detail. Then the results, only 15 RCTs were there for meta-analysis after searching more than 700 papers. So in this 15 study, 9 has used PSTT, 2 has used PMTS, and 4 has used DSR. So this was a systematic review carried for 15 studies on Unani medicine. So we can see garlic, anisun, gozaban, haldi, badranj boya, wheat germ, vitamin D3, jatamansi has been used, and primrose oil and ginger has been used. And so shambanu, pudina, and babuna. So these were the RCTs done on these Unani medicines. So for risk of bias, we have used Rovis software to create this traffic light plot, and we were able to see that from 2016, the RCT risk of assessment has showed that the good quality of studies has come from 2016. So this is meta-analysis. I'm not going in detail. We were able to see that in meta-analysis that the treatment group was better compared to control groups. So these are all meta-analysis done for the primary outcome and secondary outcome. So here we can see that RCTs were helpful to improve the PMS symptoms, and all have followed the consort guideline, and the sample size were more than 30, and the 4 trials have reported adverse effect. So there were comparison with the previous studies. Our study was an updated study compared to the other studies. So we can see, as we all know that our Unani medicine is having anti-inflammatory, analgesic, anti-anxiety and antidepressant effect. So they are the molecules which acts on GABA and which acts as a estrogen, which acts on estrogen receptors. So these are having anxiolytic, analgesic effect, and we are able to see that they are also acting on GABA. So this is how the drugs are working. So the strength is that we have used updated and PRISMA guidelines. Prospero protocol was submitted in Prospero. Risk of bias was done, side effect reporting was done, and we followed SPSS, and we were able to see that there was moderate to high heterogeneity in the study, and we only restricted ourselves to English language. So I conclude that this updated review can be breakthrough investigating nutritional supplements and Unani and herbal medicine that are possibly effective natural substitute to relieve premenstrual symptoms. However, there is a yet inadequate evidence to conclude whether nutritional supplements and Unani medicine can treat PMS. Further studies should be designed for meta-analysis and systematic review of clinical trials of other female disorders. This paper has been published in Pharmaceutics with an impact factor of 0.27. Thank you.
Next, we have a talk from Dr. Sabah Naqvi. Dr. Sabah Naqvi, she is Assistant Professor, Department of Pharmacology, NIPER, Raebareli. She'll be delivering her talk on pharmacological role of natural products based nano platforms in neurodegenerative disease. In the meantime, she's having some. You can just, we are just trying, I think you can just explain your work.
Very, very good afternoon. I know you people are very busy and you have to go. So what we are going to discuss today, because this is a, like, it's not a presentation, it's a general, I think only few people are there. Okay, your title is now, it's fine? Okay. Innovation in Unani Medicine for Integrative Health Solution, a way forward. What we are going to deliver today is, like my title was, pharmacological role of natural products. Yes, thank you. Okay, so this is my title. I'm from NIPER Raebareli, working there. So although I'm not working on the nano, I'm not working in the Unani, but as you are way forward, we are discussing over here. So it is very important to discuss something that is a new drug delivery system, or what can be. I'm a little bit fast because of the request. So what is very important, here you can see everybody knows, I will not go into detail with nanotechnology, because at the nano level, when the drug is poised to the 10 to the power minus 9, what happened, their property is drastically changing. That's why we know very well, I'm just concluding it within 5 minutes, that's what is the problem with the current methodology, or you may say might be linked with the Unani medicine system also. Sometimes the poor absorption from the target site, as well as the poor viability, as well as the high phosphorus metabolism, these are all problems not associated with the traditional drug delivery system, but also with the nano system. So here you can see the nano can be used in multiple therapies. You know very well, nano is widely used in the drug delivery as well as the gene delivery and the regenerative medicine and imaging and devices. So why not nano can be incorporated in the Unani system? This is the question. A way forward also, the innovation can be done when we are using the nanotechnology in the Unani system. Here you can see many nanoparticles, like the polymeric nanoparticle, liposomal nanoparticle, and other inorganic, organic nanoparticle is widely used and present in the market that can be used. We can also use this traditional medicine, which is already have some data, but not the evidence-based studies much done in the use with the nanotechnology. Here you can see. But what I found while searching that how FDA issued the final guidance related to the nanotechnology, many guidance document is present at the FDA, and India also, DBT also has published this document for the nanotechnology. But I request the people who are working on the policy matter, as well as who is preparing this guidance document, you can also have some document where if people want to work in the nano, right, how they use the Unani system. They can develop this kind of guidance system for the Unani system, right, using the nanomaterials. There are the various topics are there. There's some recommended factor for assessment on nanomaterial, because when the drug is going to decrease, they're too much low level, like the 10 to the power minus 9, their pharmacokinetic, their metabolism, their everything, route of administration, as well as the physical state of administration. This is all as per the FDA guideline, that the property can be checked at the nano level. What we can integrate with the Unani system, that when we are using the nano in Unani, what can be, as per the FDA, although the guidance document is not available, but we can use these parameter which is already mentioned there and develop some good and effective drug using a new drug delivery system. Might be it more be like useful. So these are the various example of the nanomaterial based drug delivery vehicle which is available. I will not go in detail. Nanosystem, many nanosystem under the clinical trial stage that we can also use for the human, like some what I have seen earlier. I do not have that much idea about the Unani, but last 2 days I have seen many drugs are there. In the similar way, we can use the nanosystem and use in the clinical trials. We have a good hospitals in Unani system also. So these are that is what I said, okay, I'm just finalizing. These are regulatory agency across the world, but in India also we have the guidance. I'm again saying if we want to do nano in Unani system, there is any guidance document? If it's not there, please, those who are working over it, they can also say a new way how to develop and integrate with the new system. So these are the few examples which we have done in our lab, because I've seen somewhere somebody has checking the constituent and berberine is on the top. I have seen, might be Dr. Mariam has shown some data. So I have checked the berberine for the against the Parkinson model, and we have checked the efficacy of that. PLGA, PBAG is the, okay, I'm just finishing. You can see how the other hepatotoxicity, these are all our data, what we are doing in our lab, and you can see the different particles, nanoparticle using the biodistribution. We can do many things with this, with the different imaging system. I am not showing all the data we have already done, because we are from the pharmacology and toxicology lab. We always done the molecular mechanistic approach also using the Western blot, everything. But here we are showing only few of the nanoparticle which is used. We can also use it, okay, madam? So here, okay, this is all data which we have done in our lab. We have also, because you are using the gold in your some of the Unani formulation, so we are preparing the hollow gold nanoparticle and check against the multiple sclerosis. This is one of the area that we can integrate with our system and increase their efficacy and safety. Although we have to do as per the OECD and other guideline, then only we can say it is safe and strong. So I will conclude it. I will not show more result. Okay. So at least I should say 10 seconds. Integrating tradition with innovation is very important. So exploring innovative drug delivery system, this is the theme what I thought this is the theme, that how could we explore the new drug delivery system and the pharmacological properties of that system, that what we have developed. Thank you very much, sir, because he has come. So it is really good and bad. I could not say it is very bad sometimes, but of course, if you are doing some work and if the audience is there, but audience is not there, all are well qualified professors are sitting, no need to say much. Okay, thank you very much for giving me this time. Okay.
It's really embarrassing how we are treating our guests, but I'm also receiving calls from sir that we have to wind up actually. So finally, but even then, though we have rushed our presentations, a formal conclusion is necessary. So for that, I invite Dr. M.A. Wahid to please felicitate our chairperson, Professor Azad Khan, sir. Thank you so much, sir, for being here. I request Dr. Imamuddin to please join us on stage during the felicitation. Sir, please. It's an honor to have you here. Amir Jahan. Next, I request, sir, please remain on dais. I request Wahid sir and Imamuddin sir to please felicitate Dr. Amir Jahan. मैम आप भी आ जाइए ना. हाँ हाँ. Now I request sir to please felicitate Dr. Sharifa bint Saeed Abdul Rahman. A pretty long, small name. Irfat. Irfat Ara. Now I request sir to please felicitate and Dr. Irfat Ara, Deputy Director, RRIM Srinagar. Ma'am is heading one of our prime institute. Now I invite all the speakers to please come up on stage so that we can at least have a group photograph. At least have a group photograph. ले लीजिए ले लीजिए. कोई नहीं ऐसे आ जाएंगे सब. फोटोग्राफ एक ग्रुप फोटोग्राफ.